इसमें तो रंजीत भाई का ही आ रहा है। हाँ लेकिन आ नहीं रहे ना, कुछ करें डायरेक्टली साइड में डाल दो। आ गया। Alright, hi guys, a very good afternoon to all of you. I hope I'm clearly audible and visible to all of you guys. Hi everyone, all those students, those who are live. I think this session was scheduled for yesterday, but due to some technical issues, I think we could not continue this session yesterday. So we are going to do this session today. Please give me a quick confirmation if I'm clearly audible and visible to all of you guys. If everything is fine, I'll immediately start the session. Okay, good. So let's get started with the test and discussion batch, and in this test we have roughly around 50 question, and we'll try to cover this 50 question, and not only we are going to discuss the answer to this question, but we are also going to discuss the why behind the answer, and our purpose will also be to make sure to discuss the other option, because usually in upcoming examination the examiner will be focusing on question, or they'll be making the new question especially from the other option that has been given, right? So I am Dr. Siraj Ahmad, your faculty of pharmacology, and I'll be taking care of your pharmacology, and will make sure that your journey in pharmacology goes the smoothest that you have ever imagined, right? So let's go and discuss the very first question that we have. I think all the students, those who are live right now, they can clearly hear me. Audio and video both are fine. So the very first question that we are having is, which of the following diuretic and its ADR is correctly matched? Please give me guys a quick thumbs if you guys have got this question and what's the answer that you have given. The more answer you give, the more amount of information you'll be able to get from me, because again if I'll be able to know that you guys are making mistake in this XYZ topic, I'll be in a position to understand what are the weakness and what are the important area that we need to focus. Okay, so please give me a quick confirmation for a question like this. This live discussion, it goes like this, right? Live interaction hota hai, ya we just simply discuss and go? I hope it will be an interactive class, and I want it to be interactive class, because the more you interact, believe me, the more you will end up learning. So which of the following ADR, diuretic and ADR is adverse drug reaction, is correctly matched? Anyone who would like to answer this one? We have chlorothiazide, that is one of the thiazide diuretics. Chlorothiazide, that is one of the thiazide diuretics, that is given hyperkalemia. Acetazolamide, it is causing hypercalcemia. Furosemide, hypercalciuria. And spironolactone, that is causing metabolic acidosis. Okay, so let us first go and try to discuss the important side effect of the diuretics and what are the side effects of all the diuretics. So remember, important site of the diuretics that we know, important site, if I tell you that on the proximal convoluted tubule, which diuretic will be working? If you know already, on the proximal convoluted tubule, the diuretic that is going to work will be your carbonic anhydrase inhibitor. This carbonic anhydrase inhibitor often and usually be causing loss of water, loss of sodium, and loss of bicarbonate. Now usually remember, we are not worried about sodium. Why? Because if you inhibit the sodium reabsorption at the proximal convoluted tubule, they will be reabsorbed from the later part of the nephron, because we have, let's say, loop of Henle where we have sodium potassium 2 chloride, and we are also having distal convoluted tubule where we are having sodium chloride, and also in the collecting duct also. So we have multiple more space and place from where sodium can be reabsorbed. But the problem comes for the bicarbonate. Wherever there is a problem with the bicarbonate, that means if you inhibit the reabsorption of bicarbonate at the proximal convoluted tubule, the bicarbonate will not be reabsorbed, and therefore this loss of bicarbonate will lead to two important things. One will be, inside the body bicarbonate will be lesser, leading to metabolic acidosis. metabolic acidosis. And urine, once again the bicarbonate will be more, so there will be bicarbonaturia that will be leading to urinary alkalosis. So remember, this one drug, carbonic anhydrase inhibitor, by the name of drugs like your acetazolamide, dorzolamide, brinzolamide, all of them are carbonic anhydrase inhibitor. Acetazolamide, brinzolamide, dorzolamide, है ना, brinzolamide, they are carbonic anhydrase inhibitor, and they are going to cause metabolic acidosis and urinary alkalosis. So what we understand here, that they are one of the urinary alkalinizer. They can cause alkalinosis, alkalinization of the urine, and that is why we also use them in a patient with the एसिडिक ड्रग पॉइजनिंग. एसिडिक ड्रग पॉइजनिंग में भी हम कार्बोनिक एनहाइड्रेस को यूज करते हैं. इनफैक्ट इफ आई हैव टू समराइज द इंपॉर्टेंट यूजेस ऑफ दिस कार्बोनिक एनहाइड्रेस इनहिबिटर, आई कैन टेल यू दैट द यूजेस कैन बी रिमेंबर्ड बाय द वेरी सिंपल mnemonic called MEGA. MEGA are the very simple uses. MEGA stand for your mountain sickness. MEGA stand for your mountain sickness. It can also be utilized for epilepsy like catamenial epilepsy. It can also be utilized for the glaucoma. Drugs like your dorzolamide, it's a very preferred, very mild drug for pediatric glaucoma, right? And also we can use it for the alkalinization of urine. So alkalinization of urine will be mainly required in acidic drug poisoning. It will be mainly required in the acidic drug poisoning. So usually in acidic drug poisoning we do forced alkaline diuresis using soda bicarbonate, है ना. क्या यूज करते हैं? We do forced alkaline diuresis using soda bicarbonate, but we can also use carbonic anhydrase inhibitor. These are the different uses, right? And remember, the mnemonic is going to be MEGA, and I was discussing here the side effect. They are causing metabolic acidosis, urinary alkalosis. इसके अलावा the other side effect that they can cause, apart from this other side effect that they can cause, these are the side effects. They can lead to paresthesias. They can cause paresthesias of the upper limb, lower limb and upper limb का paresthesia करा सकते हैं ये, ठीक है. That is going to be your carbonic anhydrase inhibitor. They can also increase the risk of renal stone. Risk of renal stone के risk को भी also they used to increase, है ना. We are discussing mainly at the level of PCT only. There is no space here, so I will discuss some important points on the next slide. We have diuretics next, that is going to be loop diuretics, and we have diuretic that is by the name of thiazide diuretics. Loop diuretics and thiazide diuretics, these are the other two diuretics, loop and thiazide diuretics. The loop diuretics as a diuretic, the name itself is loop, that means they are acting mainly at the thick ascending limb of loop of Henle. Thiazide diuretics, they are going to act mainly at the early part of DCT, that is distal convoluted tubule. They are going to work, loop diuretic, they act by blocking a co-transporter called sodium potassium 2-chloride co-transporter. Thiazide diuretics that we have, they are going to act by blocking NaCl co-transporter. NaCl co-transporter को they act by inhibiting NaCl co-transporter. Now what are the loop diuretic that you know? Important loop diuretic that we know is known as your furosemide, torsemide. There are many other, है ना, like ethacrinic acid and all. We are not writing everything about those, है ना, important ones only. And under thiazide diuretics we are having hydrochlorothiazide. We have drugs like your hydrochlorothiazide, chlorthalidone, that is one of the longer acting one. And because chlorthalidone is one of the agent that is having longer T half-life, remember this chlorthalidone as a drug is having longer T half-life, it is more commonly utilized. It is going to be more commonly utilized. Now we have other drugs like your indapamide. And we are also having drugs like your metolazone, indapamide, and we also have drug like your metolazone. So these are the other compounds that we have under the thiazide diuretics, and all these diuretics, be it loop diuretic, thiazide diuretics, they share some common side effect and some of the, like, let's say, uncommon side effect. So important side effect, if you are going to see, they both of them they will be causing loss of sodium. So there will be hyponatremia, hypokalemia, और क्या कॉज कर सकते हैं ये? They can lead to also, है ना, metabolic alkalosis. the diuretic that was causing acidosis, was metabolic acidosis, that was carbonic anhydrase inhibitor mainly remember I am using the term, so loss of sodium, loss of potassium, they can also lead to metabolic alkalosis. In addition to that, if I tell you, your loop diuretics, they also can decrease, इसके साथ they will also cause decreased amount of calcium as well, because what we know, loop causes loss of calcium. So if the calcium will be excreted in the urine, can I call this one as a hypercalciuria? Look at the term that I am using, hypercalciuria, and this is the exact term what examiner also prefers for your examination. Now hypercalcemia मैंने नहीं लिखा, I have written hypercalciuria. So hypercalciuria means more and more loss of calcium. Okay, that is hypercalciuria. Okay, what about your loop diuretics के बाद thiazide diuretics, so they will also cause loss of sodium, potassium, metabolic alkalosis, ये दोनों के साथ common है. इनके अलावा they will also increase the level of uric acid, therefore they can actually precipitate gout. So one of the very famous question that they also ask, बार पूछते हैं, that which of the following diuretic can precipitate gout and should be avoided in gout patient. It is this diuretic, that is thiazide, that we have. It can also increase the level of glucose. Now glucose level can also be increased by your loop, but the risk is much lesser as compared to thiazide diuretics. So they can also increase the glucose level, hyperglycemia, and they will inhibit the loss of calcium. So the level of calcium will also be higher. So they can lead to hypercalcemia, hyperglycemia, and increase in the uric acid level. On the other hand, if I talk to all of you guys, that loop diuretic was causing loss of calcium. This explains the fact that why in examination, when the examiner asked that which diuretic is preferred in a patient with renal stone and which diuretic is contraindicated. So here we have the answer to both the question. This is going to be contraindicated in a patient with the renal stone patients. Why are they contraindicated in renal stone patient? Let's understand why are they contraindicated in renal stone patient. Let's say this is the kidney that we have, right? This is the kidney that we have, and in this kidney there is already some stone present. मान लीजिए इस kidney पे already कुछ stone present है, ठीक है? If there is some stone already present and you are going to see that you are going to give a diuretic that is causing further loss of calcium, so more and more calcium will be coming, and where is this calcium will get excreted? They will pass through the renal parenchyma, and this stone, which is already pre-existing renal stone, more and more calcium will also pass through this, and there will be precipitation, saturation of the calcium in the parenchyma, and they can actually increase the renal stone size. इसीलिए renal stone patient में we actually do not give loop diuretics, and also they are going to be contraindicated in a known hypocalcemia patient. अगर कोई hypocalcemia patient है तो we should not give loop diuretics, because hypocalcemia itself is an emergency condition, and you do not give a diuretic that further increase or precipitate this emergency. This one thiazide, on the other hand, this is going to be a preferred diuretic in a renal stone patients. And they are preferred diuretic also in a known case of preferred diuretic in renal stone patient and preferred diuretic in a patient with the hypocalcemia history. Hypocalcemia की अगर history है, or if the patient is having hypocalcemia, which diuretic can be used? We can use thiazide diuretic. Remember, I am using the term which diuretic will be used. I am not saying that thiazide diuretic should be used for the active management. नहीं, मैंने ये कभी नहीं बोला. Thiazide diuretics is a very slow acting diuretic. It's a long acting diuretic. Hypocalcemia is an emergency. In emergency, you cannot give the slow acting diuretic. So you need to give a faster acting agent like calcium gluconate is something that you can utilize in this patient, right? So I think ये सारी बातें loop and thiazide diuretics की यहाँ पे clear होती हैं, and all of you guys have got this one. Let me just put this little more center. हाँ, तो ये आप आराम से कर पाएंगे. Now in addition to this, remember we are also having one more kind of diuretic, that is called your potassium sparing diuretics. Potassium sparing diuretic that we are having are going to be remembered by the very simple mnemonic of SETA, SETA, that stands for your spironolactone, eplerenone, spironolactone, eplerenone. We are also having drug that is known as your triamterene and amiloride. triamterene, and other one is known as your amyloride. So this is going to be your potassium sparing diuretic, and you can remember very easily by the simple mnemonic of SETA. Now there is one more thing that I will add to this one, that is ऊपर वाले दोनों, that is spironolactone and eplerenone that we have, ऊपर वाले दोनों spironolactone and eplerenone, they are mainly your aldosterone receptor blocker, and नीचे वाले दोनों triamterene and amyloride, they are the epithelial sodium channel blocker, I would say ENaC blocker, epithelial sodium channel blocker, or I would say ENaC blocker, है ना. So these are potassium sparing diuretic. They are associated with some of the important side effects. For example, if I ask you their important side effect, because they're potassium sparing, they are often added with other diuretics, like because all the other diuretic will be causing loss of potassium, they are the only one that is going to save the potassium. So they can increase the risk of hyperkalemia, and that is why they should actually be avoided with any of the RAAS system inhibitor. What is the RAAS system inhibitor? Any drug that is coming under the ACE inhibitor, any drug that is having ARB property, ACE inhibitor, ARB, ये सारे के सारे drug, they cause hyperkalemia. They all cause hyperkalemia. So with them we should avoid them. But with other diuretics, yes, we can use them with the other diuretics. What are the other side effects? Drugs like your spironolactone, remember guys, they are having anti-androgenic property because they have a metabolite, and the name of the metabolite is canrenone and 7-alpha spirolactone. Now what is canrenone? They have anti-androgenic property. A detailed discussion of this we'll be doing definitely once we go and talk about renal chapter in your live and also in the recorded session. But as of now, remember that spironolactone का एक ऐसा metabolite है which is enemy of your androgen, your own manly hormone. So they can give rise to the gift of gynecomastia. ये क्या देते हैं? The gift of gynecomastia, है ना, प्लस एक दुख भरी दास्तान, decrease in the libido as well. ठीक है. So gynecomastia, decrease in the libido. अगर फीमेल की बात करें तो there can also be menstrual irregularities can also be seen. Menstrual irregularities can also be seen. So this is about your potassium sparing diuretic, specifically spironolactone. और अगर किसी पेशेंट को ये गिफ्ट मिल गया, spironolactone का गिफ्ट मिल गया, then you are supposed to shift this patient to eplerenone. आप इस पेशेंट को कहाँ शिफ्ट करोगे? eplerenone पे शिफ्ट कर दीजिए, because they do not have any anti-androgenic property. One more MCQ that I can squeeze down from this topic is amyloride as a drug. It is considered the drug of choice in a patient with the lithium-induced diabetes insipidus. Amyloride is a drug that is considered the drug of choice in a patient with the lithium-induced diabetes insipidus. One more MCQ that I can squeeze. See, every point can be a very potential MCQ, and when you solve PYQ, you will realize that how beneficial is this discussion, because all the high yield points and any question that has been asked in the previous 4-5 years on this topic is being covered here, right? Spironolactone is a drug that is also utilized in a patient with a chronic congestive heart failure, and remember they have mortality related benefit. They decrease the mortality as well. Which drug is this? This is spironolactone. Okay. So again, they both can be utilized, spironolactone and eplerenone. As a matter of fact, ये aldosterone receptor blocker के बारे में बात हो रहा है. ठीक है. So again, let's read the option once again. Chlorothiazide is a thiazide diuretic, so they are going to cause hypokalemia, no, not hyperkalemia. They will be causing hypokalemia. Acetazolamide, does it have any role on the calcium? Which diuretic was causing hypercalcemia? It was a thiazide diuretic that was increasing the risk of calcium, and loop loses calcium, so loop causes hypocalcemia. So again, this is also wrong. Acetazolamide does not cause hypercalcemia. Furosemide is a loop diuretic. Loop loses calcium. Where will they lose? In the urine. So we call them hypercalciuria. What do we call them? Hypercalciuria. Is spironolactone leading to metabolic acidosis? Yes, it can cause, but do remember the metabolic acidosis that we have as a side effect. Metabolic acidosis as a side effect is mainly going to be associated with your carbonic anhydrase inhibitor. They will have much lesser risk. So अगर आपके पास दो ऑप्शन है C and D, remember C will be more preferred as compared to D. Two answer is possible here, but C is always going to prefer. So most correctly match is going to be your furosemide leading to hypercalciuria. That is the correctly matched one. Okay. Next one is about a 9-year-old boy who was brought with a nocturnal enuresis. Nocturnal enuresis in a 9-year-old boy, again this is not normal. Up to 5 years we can consider, but again beyond 5 years not normal. If any one of you I have seen in any patient, or you know someone, remember this is not normal. So serum analysis shows reduced ADH level. You are suspecting this condition to be central in origin. Okay, so reduced ADH level, तो कहाँ से ADH कम हो गया? ब्रेन से ADH कम हो गया. If there is a reduced ADH from the brain, ADH is antidiuretic hormone, also given the name as a vasopressin. Vasopressin कम हो गया ना. अब आप मुझे बताइएगा, पहले तो इसका जवाब दीजिए आप लोग. Naman Patel is saying C. Okay. Other students also? Which agent is preferred? So ADH कम हो गया, right? So wherever ADH is lesser, what will happen? What is the role of ADH? Do you know? Let me just give you a very conceptual image that is a very favorite for my students. It has been favorite. It is favorite for me as well. So just try to understand this. Imagine this is one of the segment of a collecting duct. I hope it is pretty visible. And in a normal scenario, what happens in this segment of the collecting duct? In a normal scenario, remember we have on the collecting duct, let's say ये intracellular हो गया and बाहर वाला extracellular, and in this segment of collecting duct we have some receptor and the name of these receptors are going to be your V2 receptor. The name of these receptors are going to be V2 receptor, that is vasopressin receptor. Whenever a brain is going to give you V2 or I would say vasopressin, मान लीजिए ये vasopressin जिसको हम बोलते हैं antidiuretic hormone that is coming from the posterior pituitary, whenever this V2 receptor, V2 is getting stimulated by ADH, जिसका दूसरा नाम क्या है? Vasopressin. So when they are going to stimulate this V2 receptor, after getting stimulated this V2 receptor, what they are going to do, they are going to upregulate the level of aquaporins. So जो aquaporins that are present in the cytoplasm, now they are going to be more available on the surface. So this is going to be your aquaporin 2. Now when aquaporin level is going to be high here, what will this aquaporin do? They are the pure water channel, so they are going to cause more and more reabsorption of water. इसीलिए तो इसका नाम है एंटी डायूरेटिक हार्मोन. डायूरेसिस मतलब ज़्यादा यूरिन को बाहर करना, एंटी मतलब उल्टा है ना, एंटी डायरेटिक हार्मोन. से रिमेंबर दे आर गोइंग टू कॉज रीअब्जॉर्प्शन ऑफ द वाटर. ये नॉर्मली लेट्स से वी आर वर्किंग इन वन very hot climate and the body needs to save water, so posterior pituitary will give rise to ADH and ADH will be acting on the V2 receptor and they are going to cause stimulation of the aquaporin 2 receptor, or that will be causing upregulation of aquaporins from cytoplasm. They will be moving on the surface and they cause more and more reabsorption of water inside the body. So water को body में ले लिया. Now in this scenario where the ADH level is already very less, do you know that if the ADH level is already very less, we have some V2 receptor, they might be waiting that okay vasopressin आ जाओ. कहाँ हो vasopressin? आ जाओ. vasopressin के इंतजार में they are sitting, but again vasopressin is not there because I told you that there is less ADH, so vasopressin is not there, vasopressin is not coming. Now if no vasopressin or I would say ADH को लेकर के मैंने बोल दिया question mark, so they will keep on waiting but ADH will not come. What will happen to the aquaporin? Again they are going to be a question mark. That means aquaporin भी surface पे नहीं आएगा. No aquaporin, that means what will happen to the water that was present here? The water that is present here will now be lost in the urine and they can lead to a condition called your polyuria. They can lead to a condition called your polyuria. Urination ज़्यादा होगा ना. हाँ. So this is going to be brain जहाँ से ADH कम आया. ठीक है. अब एक और समझ लीजिएगा. In the same scenario there is one more condition where we see that brain is giving normal amount of ADH. उसमें कोई कमी नहीं कर रहा है. There is a normal pituitary that is giving normal amount of ADH, वो normally दे रहा है. Antidiuretic hormone is coming normally from the brain. But what happens in the next scenario is there are V2 receptors and I want all of you guys to compare these V2 receptors with the V2 receptor that I have done earlier. जो ये V2 receptor मैंने पहले ड्रॉ किया है, आप इस V2 receptor को इस वाले V2 receptor से कंपेयर करिए. Do you see some difference? Yes or no? Yes, you will see some shape का alteration मैंने शो किया है just to show you, just to tell you that V2 receptor is actually going to be resistant. If the V2 receptor is resistant or the V2 receptor is not going to get stimulated by the normal amount of antidiuretic hormone, do you think this V2 will get stimulated and will cause aquaporin generation? Once again, no, they will not be able to cause. Once again, what will happen? Polyuria, polydipsia, because यहाँ पे भी aquaporin generate नहीं होगा. There will be no aquaporin generation here as well because V2 receptors are not getting stimulated. Making sense? Now, since I am discussing this one, I will discuss one more very conceptual in the same image. As I told you, this is my favorite image, and we always have been using this image for quite long. And we see here that एक ऐसा ब्रेन है आपके पास जहां से ADH तो आ रहा है, बहुत ज़्यादा ADH आ रहा है. So this brain is going to give rise to too much of ADH, too much of the anti-diuretic hormone that is coming from the brain. तो इसको बोलेंगे if there is too much or inappropriate ADH that is coming more than what is required, we are going to name it as a SIADH. Oh no, what is SIADH? Syndrome of inappropriate ADH secretion. Syndrome of inappropriate ADH secretion. Now what will they do? They are going to cause all the V2 receptor का stimulation. तो जितने भी V2 receptor हैं, all these V2 receptor will get stimulated. Now imagine if all the V2 receptor are getting stimulated by anti-diuretic hormone, don't you think there will be more upregulation of aquaporin 2 on the surface? Hello, don't you think? All of you guys, are you guys listening to me? Yes, है ना? तो यहाँ पे क्या होगा? यहाँ पे there will be too much aquaporin generation, and too much aquaporin generation that we have is going to cause more and more reabsorption of water, and more reabsorption of water का level will be too high, will lead to a condition called your dilutional hyponatremia. They can lead to a condition called your dilutional hyponatremia. ठीक है, dilutional hyponatremia, है ना. So this one is going to be a case of SIADH, syndrome of inappropriate ADH secretion. Point number 1. This one, the first one, है ना, उसका नाम बताइए क्या होगा? Because brain itself is not giving ADH, we are going to call this condition is central in origin, or we are going to call it as a central diabetes insipidus. क्या नाम दिया मैंने? Central diabetes insipidus. In the other one, where ADH is coming normally, but they are not able to stimulate the receptor because there are some receptor level problem at the level of kidney, तो उसको हमने नाम दिया nephrogenic diabetes insipidus. I hope it is making sense to all of you guys. Nephrogenic diabetes insipidus. So and तीसरा मैंने आपको क्या बोल दिया? SIADH. अब जब मैंने तीनों बता दिया तो ड्रग्स के बारे में बात करेंगे, बिकॉज फार्मा, वो फार्मा ही क्या जिसमें ड्रग्स का डिस्कशन ना हो, है ना. वो दिल ही क्या जो कम से कम 3-4 बार ना टूटे, वो फार्मा ही क्या जिसमें ड्रग का डिस्कशन ना हो. जल्दी बताइए, है ना. नॉर्मल तो मैंने बता दिया. ADH इज नॉट कमिंग फ्रॉम ब्रेन, सो व्हाट वी डू, वी गिव अ सिंथेटिक ADH. तो हम सिंथेटिक स्टिमुलेशन करते हैं, वी गिव सिंथेटिक ADH का एनालॉग हम देते हैं, that will behave like ADH. So we are going to give a synthetic ADH in the central diabetes insipidus, and synthetic or ADH stimulation by a drug known as your desmopressin. The name of the compound is your desmopressin. This desmopressin is considered the drug of choice in this patient. Desmopressin is considered as a drug of choice in this patient, synthetic agent desmopressin. So again, when you're suspecting this agent, this condition to be central in origin, I think you already have the answer. The answer to this question is going to be desmopressin. Now let me summarize some of the important points on the next slide. Point to be noted, number 1, that the drug of choice for the central diabetes insipidus, guys, that is going to be your desmopressin. This is the take home message from this question. Desmopressin is the drug of choice for central diabetes insipidus. Then if the examiner is going to ask you drug of choice for nephrogenic diabetes insipidus, this is going to be nephrogenic diabetes insipidus. We actually use the drug of choice as a thiazide diuretics. So they have an alternative mechanism, that is through which they increase the cyclic AMP, and more cyclic AMP mediated aquaporin generation will be done, and those aquaporin will be causing water ka reabsorption. However, if the examiner is going to ask you lithium induced diabetes insipidus, the answer to this question is going to be amyloride. which is one of the epithelial sodium channel blocker, because lithium is going to utilize the same sodium channel to come inside the body. And last but not the least will be SIADH, syndrome of inappropriate ADH secretion. So too much ADH was getting released from the brain and they were causing too much stimulation, right? Too much stimulation. And remember, too much stimulation जब होगा तो problem होगा ही, तो we should give a V2 receptor blocker. And what are the V2 receptor blocker? Drugs like your conivaptans, and other one is the tolvaptan. Now sometime examiner also asks that conivaptan, tolvaptan, they are being utilized as a drug of choice in SIADH, but they are also used in a patient with the hyponatremia के मैनेजमेंट में, स्पेशली ड्रग लाइक टोलवेप्टान को ध्यान से देखोगे तो नाम में आता है ओरल, कोनिवेप्टान IV. तो कोनिवेप्टान इज द इंजेक्टेबल एजेंट, टोलवेप्टान इज द ओरल एजेंट. ठीक है. हाइपोनेट्रीमिया दे कैन ऑल्सो बी यूटिलाइज इन अ पेशेंट द क्रोनिक कंजेस्टिव हार्ट फेलियर, उसके लिए भी इनका अप्रूवल हो गया है. क्रोनिक कंजेस्टिव हार्ट फेलियर के लिए भी ऑल्सो वी कैन यूटिलाइज दिस ड्रग. आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू गाइज. Hello, I hope all of you guys have got this one. Now everything around this question we have covered and every option has also been discussed. If you pay clear attention, chlorothalidone is the drug of choice for nephrogenic diabetes insipidus, amiloride is the drug of choice for lithium induced diabetes insipidus, and conivaptan is the drug of choice for SIADH. Done. Next one. ये क्वेश्चन बताइएगा. True about the receptor present and its action in the eye. True about the receptor present and its action in the eye. Go ahead please. ABC में बताइए. What's your answer? Circular iritis muscle M1 receptor causing mydriasis. Radial muscle M3 receptor causing meiosis, ciliary muscle M3 receptor relaxation of the ciliary muscle, and ciliary epithelium, this is ciliary actually, I think कुछ setting का issue हो गया है. Ciliary epithelium working on beta receptor causing aqueous secretion, है ना. कुछ ऐसे क्वेश्चन जो आपके होश उड़ा देंगे एंड आपका एग्जामिनेशन यही क्वेश्चन पूछ रहा है. This is the type of question examiner is asking because your pharma has become clinical pharmacology. You have to upgrade yourself according to the syllabus. If you think कि पहले वाला जो क्वेश्चन था वैसा ही क्वेश्चन आएगा and I'll study in the same way, है ना, वही पुरानी स्टाइल में, again you will be able to solve some question but not all question. Imagine if a question like this is going to be asked, what will be your answer? Other students are saying C, some are saying B. Okay. चलो मैं थोड़ी बहुत बात करूंगा, देन आई विल कम बैक टू दिस वन एंड आई विल गिव यू वन मोर चांस टू रिवाइज योर आंसर. ठीक है. थोड़ा सा आई थिंक वी नीड टू ऐड अ स्लाइड हियर, जस्ट गिव मी अ मिनट. ओके. ऑलराइट. नाउ इमेजिन इन द आई, इफ यू आर गोइंग टू लुक एट द आइरिस, सामने से देखोगे तो आइरिस आपको दो मसल आइरिस के आप क्लियरली बना सकते हो. टू मसल इन द आईज दैट यू कैन इजीली ड्रॉ. व्हाट आर दोज टू मसल इन द आई दैट यू कैन ड्रॉ? वन इज सर्कुलरली अरेंज्ड एंड व्हेन इट इज सर्कुलरली अरेंज्ड वी कॉल दिस वन एज अ सर्कुलर आइराइडिस मसल. क्या बोलते हैं इनको? सर्कुलर आइराइडिस मसल. द वन दैट इज सर्कुलरली अरेंज्ड इज सर्कुलर आइराइडिस मसल. ठीक है. तो इसको देखते हैं. इसके अलावा देयर इज वन मोर ग्रुप ऑफ मसल दैट इज अरेंज्ड रेडियली और इसको हमने नाम दे दिया रेडियल मसल. ठीक है. अब देखिएगा इन द आई देयर इज सिंपैथेटिक एंड पैरासिम्पैथेटिक, बोथ काइंड ऑफ टोन इज अवेलेबल. The one that is radially present, this muscle is given the name as a radial muscle, and other name of this radial muscle is dilator pupillae muscle. Other name क्या होता है इनका? Dilator pupillae. अच्छा, जब dilator pupillae नाम है तो आप खुद ही समझ सकते हैं ना कि they will be causing dilatation of the pupils. हाँ. तो अगेन dilator pupil है, radial muscle है. On this we are having mainly alpha 1 receptor. That is sympathetic receptor. Then we are having one more that is circular iritis muscle, and the receptor that is present on the circular iritis muscle, जो receptor इस पे present है उनको बोलते हैं circular iritis because they are circularly arranged और iris के मसल हैं तो circular iritis. Other name of circular iritis is sphincter pupillae. they are forming like a sphincter. So other name of this one is going to be sphincter pupillae. Please try to understand. एक है sphincter pupillae, उसी का दूसरा नाम क्या है? Circular iridis. So in the sympathetic parasympathetic, I used to always tell you P for parasympathetic, P for positive. So parasympathetic is having all the positive activity. Are you guys following me or not? Parasympathetic, P for parasympathetic, P for positive, they are having all the positive activity. Positive मतलब हर चीज को बढ़ा देंगे. Contraction increase, glandular secretion increase, motility increase, eye का contraction भी बढ़ जाएगा. eye का contraction बढ़ गया मतलब they will be causing meiosis. Now which receptor of parasympathetic is present on the circular iridis muscle? Hello, please give me the quick reply. All the students those who are live, है ना. आप लोग इंटरेक्ट नहीं कर रहे हैं. मैंने आपको बोला था मेरे से सीखना है तो बहुत इंटरेक्शन करो, बहुत गलतियां करोगे उतना ही सीखोगे, है ना. डोंट बी अफ्रेड ऑफ मेकिंग मिस्टेक. बिलीव मी, एनी स्टूडेंट हु इज अफ्रेड ऑफ मेकिंग मिस्टेक इज नॉट ट्राइंग इनफ. ठीक है. ज़्यादा से ज़्यादा क्या होगा? गलत ही होगा, कुछ नहीं होगा, उससे ज़्यादा कुछ नहीं होगा, है ना. आप इससे मत घबराइए कि मैंने गलत जवाब दे दिया तो मेरी क्रश देख लेगी, क्रश देख लेगी तो मुझे क्रश कर देगी, है ना. ऐसा कुछ नहीं है. क्रश को भी नहीं आता है, पता है आपको. उनको भी नहीं आता है. तो इसलिए स्फिंक्टर पिपिले पे कौन सा रिसेप्टर होगा जल्दी से बता दीजिए. ऑल ऑफ यू वेरी गुड. डॉक्टर शालू कुमारी या नहीं, शालू कुमारी, शालू नहीं है, शैल कुमारी यादव, बिल्कुल, है ना. तो शैल कुमारी हैज गिवन द एब्सोल्युटली करेक्ट आंसर M3. नाउ इफ इट इज M3, will it cause meiosis or mydriasis? Hello, it is parasympathetic, right? So they are going to cause meiosis. Okay, agreed, they are going to cause meiosis. Now if I give any M3 agonist, अगर मैं कोई M3 एगोनिस्ट दे दिया तो क्या होगा? अगर मैं कोई M3 एगोनिस्ट दे दिया तो क्या होगा? लेट्स अंडरस्टैंड. M3 एगोनिस्ट इफ आई एम गोइंग टू यूज, लेट्स अज्यूम द M3 एगोनिस्ट दैट आई एम गोइंग टू यूज इज कॉल्ड योर pilocarpine. Pilocarpine is one of the M3 agonists that we are going to use. And if I use M3 agonist pilocarpine, will it cause meiosis or mydriasis? Of course, they will cause meiosis. You are simply increasing the activity of a circular iridis muscle, and the type of meiosis that we are going to see here, we call them as a active meiosis. क्या करेंगे? एक्टिव मायोसिस करेंगे, है ना. तो इसको बोलते हैं एक्टिव मायोसिस. कॉन्सेप्ट समझिएगा. लाइफ का आई का एक बहुत इंपॉर्टेंट कॉन्सेप्ट अभी समझ में आएगा. और कई सारे आपकी, है ना, आंखों के क्या बोलेंगे, कई सारी आंखें आपकी खुल जाएंगी, है ना. इस कॉन्सेप्ट को लेकर के बहुत सारे क्वेश्चन आप इसको कर पाओगे इन अपकमिंग डेज. सो M3 एगोनिस्ट इज गोइंग टू कॉज मायोसिस. नाउ थिंक एंड टेल मी, इफ M3 एगोनिस्ट इज कॉजिंग मायोसिस, what will happen if I am going to block my alpha receptor? What is alpha? Again, sympathetic. So remember, at a time in the eye we have sympathetic, we have parasympathetic. ठीक है. हमारी आंखों में सिंपैथेटिक है, पैरासिम्पैथेटिक है. एक समय पे या सिंपैथेटिक काम करेगा या पैरासिम्पैथेटिक, दोनों एक साथ काम नहीं करते. दे नेवर फाइट विथ ईच अदर. दे वर्क आइदर सिंपैथेटिक और पैरासिम्पैथेटिक. एक समय में कोई भी एक काम करेगा. अब आते हैं आपके असली बात पे. When a parasympathetic is causing meiosis, sympathetic is causing mydriasis, at a time any one will be working. And if you are going to increase the activity of parasympathetic, तो आपने पैरासिम्पैथेटिक की एक्टिविटी को बढ़ा दिया तो यू आर गोइंग टू कॉज एक्टिव माइड्रियासिस. माइड्रियासिस बढ़ गया प्यूपिल साइज. सॉरी, इफ यू आर गोइंग टू गिव पैरासिम्पैथेटिक एक्टिव मायोसिस, यू आर गोइंग टू इंक्रीज द मायोसिस और सर्कुलर आइरिस मसल का कॉन्ट्रैक्शन. बट लेट्स से यू आर नॉट गोइंग टू डायरेक्टली कॉज एनी मायोसिस. आप पैरासिम्पैथेटिक पे कोई काम नहीं कर रहे हो, बट व्हाट यू आर गोइंग टू डू, यू आर एक्चुअली रिमूविंग द सिंपैथेटिक टोन. You are not directly doing anything to parasympathetic, but if you are going to remove the sympathetic tone, in that case scenario, what will happen? You see, if you remove the sympathetic tone, automatically parasympathetic, sympathetic के tone को हटा दिया, बिना कुछ किए ही parasympathetic tone high है ना. Parasympathetic, sympathetic, remove the sympathetic tone, parasympathetic tone is automatically high because they are unopposed now, right? So whenever we are going to give our patient any alpha blocker, we have drugs like your phentolamine. There are many alpha blocker actually. We have drugs like your phentolamine, or we are also having drugs like zosine called your prazosine, terazosine, any of the alpha blocker. Now this alpha blocker as a drug, selective, non-selective, नीचे वाला selective है, ऊपर वाला non-selective है. What kind of problem they will cause in the eye especially? Will they cause meiosis or mydriasis? Alpha itself causing mydriasis. If you block alpha, automatically the parasympathetic tone will be high, and the type of meiosis that you are going to see here is called passive meiosis. Did you guys understand this or not? Yes, very good, Dr. Kumari, Dr. Yadav, है ना? So we have a drug that is causing active meiosis, that is pilocarpine, that is any M3 agonist. Any alpha blocker will also cause meiosis, but the type of meiosis here is called passive meiosis. ठीक है, आगे चलते हैं. आगे आगे आके जब हम बात करते हैं तो हमने देखा क्या कि वी हैव alpha 1 receptor. We are having alpha 1 receptor, and this alpha 1 receptor itself is causing mydriasis. And if I am going to use any alpha 1 का agonist, अगर कोई भी आप अल्फा 1 का एगोनिस्ट यूज करते हो तो क्या होगा, सोच के बताइए. अल्फा 1 एगोनिस्ट लाइक, लेट मी गिव यू द नेम बाय फिनाइलेफ्रिन. ये कॉन्सेप्ट आपके एग्जाम में बहुत काम आने वाला है. फिनाइलेफ्रिन इज वन ऑफ द अल्फा 1 एगोनिस्ट. दे आर सिंपैथेटिक टोन. दे आर गोइंग टू इंक्रीज द सिंपैथेटिक टोन, एंड इफ दे इंक्रीज द सिंपैथेटिक टोन, व्हाट काइंड ऑफ एक्टिविटी विल बी सीन? Again, meiosis will not be seen, but mydriasis will be seen. But the type of mydriasis that we see here is called active mydriasis. We are going to call it as a active mydriasis. Dr. Vinayas S is saying why. Dr. Vinayas, आपका एक कमेंट आ रहा है why. तो why is it any concept that you could not understand, या आप ऐसे ही why लिख दे रहे हैं, या आप कुछ लिखना चाह रहे हैं और कुछ और टाइप हो जा रहा है? ऐसा तो नहीं है. Are you guys following me or not? If you increase the sympathetic tone, there will be active mydriasis. So alpha 1 agonist, they are going to cause active mydriasis, or there will be mydriasis only. Imagine there is a sympathetic, there is a parasympathetic, and this time I am telling you block the M3 receptor. If you are going to block the M3 receptor, now what will happen? Parasympathetic tone is gone. That means, sir, sphincter pupillary level action is gone. If parasympathetic tone is gone, then what will happen now? Sympathetic tone will automatically be high, right? So what will happen next? We are going to give our patient M3 antagonist. M3 antagonist, ठीक है? M3 antagonists are going to be drugs like your many drugs like your atropine, homatropine, tropicamide, cyclopentolate. बहुत सारे ड्रग है ना. Just writing few of them. Cyclopentolate, tropicamide, these are the M3 antagonists. You are actually removing parasympathetic tone. आप directly कुछ नहीं कर रहे हो. You are not directly acting on the sympathetic, you are simply cutting down the parasympathetic. बच्चे बताओ, जब parasympathetic के टोन को ही कट कर दिया तो sympathetic tone is going to be automatically high, and that explains the fact that why with a drug like atropine, cyclopentolate, tropicamide, there is going to be passive kind of mydriasis. जो mydriasis यहाँ आएगा उसको हम बोलते हैं पैसिव काइंड ऑफ माइड्रियासिस. जब आप आज रिवाइज कर रहे होगे, प्लीज मेक श्योर टू राइट इट डाउन ऑन अ पीस ऑफ पेपर. राइट योर सेल्फ, मेक योर सेल्फ, ड्रॉ योर सेल्फ. ड्रग्स कॉजिंग एक्टिव मायोसिस, पैसिव मायोसिस, एक्टिव माइड्रियासिस, पैसिव माइड्रियासिस. मैं फिर से रिपीट कर दे रहा हूँ. इफ यू डायरेक्टली इंक्रीज द एक्टिविटी ऑफ M3, दे विल बी कॉजिंग एक्टिव मायोसिस लाइक पाइलोकार्पिन. इफ यू ब्लॉक सिंपैथेटिक, ऑटोमेटिकली पैरासिम्पैथेटिक टोन विल बी हाई लाइक अल्फा ब्लॉकर, दे विल बी कॉजिंग पैसिव मायोसिस. Alpha 1 agonist, that is sympathetic tone को बढ़ा दिया. Sympathetic we already know they are present on the radial muscle. They themselves cause mydriasis. So if you increase the activity of alpha 1, they are going to cause mydriasis, and the type of mydriasis we call it as the active mydriasis. And when you block M3 blocker अगर कर दिया तो automatically parasympathetic tone is gone, and there will be more and more mydriasis, and we call this passive mydriasis. बस इसके साथ एक छोटा सा एड ऑन ये करना है. बिकॉज M3 इज ऑल्सो प्रेजेंट ऑन द सिलरी मसल, दे आर एसोसिएटेड विद पैसिव माइड्रियासिस प्लस साइक्लोप्लीजिया. बिकॉज M3 is mainly present on the ciliary muscle, they are going to cause passive myosis and passive mydriasis and cycloplegia. ठीक है, साइक्लोप्लीजिया इज सिलरी मसल पैरालिसिस, है ना. तो एकोमोडेशन यूजुअली नहीं हो पाता, आप सिलरी मसल का कॉन्ट्रैक्शन नहीं कर सकते. ठीक है, अब आते हैं आपके क्वेश्चन पे. ठीक है, ये हो गया आपका यूजुअल जोन्यूल्स, है ना. जोन्यूल्स हो गए. ऑल द जोन्यूल्स आर मेनली गोइंग टू कॉज सस्पेंशन ऑफ द लेंस. ये लेंस को ऐसे होल्ड करके रखते हैं. जोन्यूल्स, दे आर गोइंग टू होल्ड द लेंस. ठीक है. एंड एंटीरियरली इफ यू सी वी हैव द आइरिस, एंड आइरिस का ये तो लेटरल व्यू में दिख रहा है ना, तो आपको लेटरल में से दिख रहा है. देन आइरिस के आगे अगर आप देखोगे तो हियर वी आर हैविंग द कॉर्निया, ये कॉर्निया हमारे पास आगे होगा. और आइरिस की जो डायफ्राम है, इसके डायफ्राम के बीच का जो एरिया है, दिस वन इट इज कॉल्ड प्यूपिल. आइरिस के बीच का, तो आइरिस लाइक दिस है ना, और बीच का जो एरिया जो बड़ा होता है छोटा होता है वही तो है प्यूपिल, है ना. बेसिक एनाटॉमी, बेसिक ऑफ्थेल्मोलॉजी, ठीक है. Back here we have our retina on which the image formation will be seen. Back here we have the retina on which the image formation will be seen. One thing that we know that here ciliary muscle is mainly there in connection with the zonules. This is CM मतलब ciliary muscle. Anterior finger like projection is pars plicata and posterior plane वाला structure will be pars plana. पार्स प्लेना और एंटीरियर फिंगर लाइक प्रोजेक्शन जो है उसको बोलते हैं पार्स प्लिकाता, ठीक है. ऑलराइट, तो ये सिलरी मसल हो गया. ओवर सिलरी मसल ऑल्सो वी आर हैविंग M3 रिसेप्टर. एंड इन योर ऑफ्थेल्मोलॉजी यू मस्ट हैव रेड, है ना, दैट द रिलेशन बिटवीन ciliary muscle and zonules is always inverse. That means whenever there is a contraction of the ciliary muscle, there is going to be a relaxation of the zonules, ठीक. So when the ciliary muscle contracts, this is the zonules. Let's say zonules is very straight, zonules is very much tensed. Whenever there is a contraction of the ciliary muscle, the zonules is going to be relaxed. When the zonules relax, one thing is for sure that the lens, what will happen to the lens guys? Lens will become more globular. लेंस क्या होगा? लेंस will become more globular. That means लेंस का पावर बढ़ जाएगा. लेंस का पावर will increase whenever there is any ciliary muscle contraction. जब भी हम ऐसे करते हैं ना, क्या लिखा है, क्या लिखा है, सर ने CM लिखा है, कुछ तो लिखा है. So when you use your ciliary muscle contraction, you are causing relaxation of the zonules, and therefore you are causing more and more, lens will become more and more globular, and therefore the power of lens is going to increase. Is it making sense to all of you? Hello. Now on the ciliary muscle, this is the time that we have to study the important point here, that over the finger like projection on the ciliary muscle, यहाँ पे here we are having some non-pigmented epithelium, and ciliary muscle is the area जहाँ से aqueous का secretion होता है. ये information आपको सिर्फ और सिर्फ ऑफ्थेल्मोलॉजी में पढ़ाया जाएगा. बट अगर आपने इसको फार्मा के साथ कोरिलेट कर लिया तो यू विल बी एबल टू क्रैक एनी ऑफ द क्वेश्चन दैट कैन बी आस्क्ड फ्रॉम दिस टॉपिक्स, राइट. सो एंटीरियर फिंगर लाइक प्रोजेक्शन के ऊपर है हमारा नॉन पिगमेंटेड एपिथेलियम ऑफ सिलियरी मसल. एंड दिस सिलियरी मसल का जो एपिथेलियम है, दिस इज रिस्पॉन्सिबल फॉर द एक्वस का सिक्रीशन. ओके, सो नाउ वी नो दैट एक्वस का सिक्रीशन तो पार्स प्लिकाता से होता है, ये तो पता था. उसके ऊपर एक पिगमेंटेड एपिथेलियम है, नॉन पिगमेंटेड एपिथेलियम है, वहाँ से आता है एक्वस सिक्रीशन दैट इज कमिंग यूजुअली एट अ रेट ऑफ 2.2 माइक्रोलीटर पर मिनट के रेट से एक्वस का सिक्रीशन हुआ. Whatever aqueous that has been secreted from the pars plicata, they will come to this posterior chamber, then they will go to the anterior chamber, और यहाँ से जाकर के ये ड्रेन हो जाते हैं ट्रेबेकुलर मेशवर्क. वहाँ से they will go to the uveoscleral pathway, ट्रेबेकुलर मेशवर्क पाथवे है ना, वहाँ से दो पाथवे वहाँ से ये ड्रेन हो जाएंगे, है ना. वहाँ से they can from trabecular मेशवर्क they can go to the episcleral vein, and from there they can go to the systemic circulation, है ना. So again, pars plicata, anterior finger like projection is the source of aqueous production. Whatever aqueous that has been produced is going to be drained through trabecular meshwork mainly, है ना. Now circular irides muscle, उसके ऊपर कौन सा रिसेप्टर था बच्चे? We had M3. Was it causing meiosis or mydriasis? Now I'm giving you one more chance. Would you like to refine your answer? Guys? Naman Patel, video is getting stuck. No, not from my end. Possibly, please check your internet because अभी मैं स्टूडियो में हूँ और यहाँ का इंटरनेट बहुत ही फास्ट है. Any other student who is having problem with the video getting stuck? Hi everyone. Any other student getting this problem of video getting stuck? Hello. Chalo. So I'm giving you one more chance to all of you guys. अच्छा, वाई एज इन यस, ओके, शॉर्ट फॉर्म है क्या? ये तो मुझे पता ही नहीं था। विनायस ने रिप्लाई किया था, मैं देखा नहीं था सर। वाई एज इन यस, देखो इतने सारे शॉर्ट फॉर्म्स हैं कि मैं अभी उससे यूज टू नहीं हो पाया हूँ आपके शॉर्टकट से, बट आई होप कि आई गेट यूज टू वेरी सुन, है ना। सर्कुलर एडिस मसल M1 रिसेप्टर पे काम नहीं, सर्कुलर एडिस पे वी हैव M3 रिसेप्टर एंड दे कॉज ऑलवेज एंड ऑलवेज मायोसिस। ठीक है, तो पहला तो रूल्ड आउट हो गया। नाउ रेडियल मसल पे व्हाट डू वी हैव? अल्फा 1 एंड दे कॉज माइड्रियासिस, बता चुका हूं मैं। सिलेरी मसल पे भी हैव M3 रिसेप्टर एंड विल दे कॉज रिलैक्सेशन ऑफ सिलेरी मसल? नो, दे कैन कॉज सिलेरी मसल स्पाज्म, दे कैन कॉज सिलेरी मसल का स्पाज्म, दे डू नॉट कॉज रिलैक्सेशन। एंड सिलेरी एपिथेलियम पे भी है बीटा रिसेप्टर दैट इज कॉजिंग एक्वस सिक्रीशन। हाँ जी, ये करेक्ट जवाब है। सो यू गेट द आंसर व्हाट इज द लीस्ट एक्सपेक्टेड, है ना। तो ऑलवेज एंड ऑलवेज इन द एग्जामिनेशन और ऑलवेज इन योर ग्रैंड टेस्ट समटाइम द अनएक्सपेक्टेड ones are usually the correct answer. So correct answer for this one is not C, Dr. Vinayas, it is actually D that I have given you already. Next is, which of the following receptor is involved in the activation of RAAS system? ANS का क्वेश्चन है। RAAS system is renin angiotensin aldosterone system, M1 M2 beta 1 beta 2. Please tell me, RAAS system का एक्टिवेशन कहाँ से होता है? The activation of RAAS system is seen because from the kidney we have a cell that is given the name as a juxtaglomerular cell, and JG cell पे we have a receptor by the name of beta 1 receptor. So whenever there is any fall in the pressure, whenever the kidney senses less sugar, less pressure, they always cause beta 1 mediated release of renin. Now as soon as renin comes to the circulation, there will always be beta 1 mediated release of renin. As soon as renin comes to the circulation, they will activate a system, very famous system in the body called RAAS system. RAAS system में होता क्या है? They are going to call angiotensinogen conversion to angiotensin 1, and this angiotensin 1 that we have is going to get converted to angiotensin 2. angiotensin 1 से 2 में जो बदलता है, the name of the enzyme is called angiotensin converting enzyme, ACE enzyme, that is going to cause conversion of angiotensin 1 to angiotensin 2. And this angiotensin 2 is going to have two important functions. Function number 1, they are going to act on its receptor by the name of AT1 receptor, that is going to cause vasoconstriction. Ultimately the BP will increase. Angiotensin 2, they are also going to work at the zona glomerulosa of the adrenal gland. ZZ मतलब zona glomerulosa, तो एड्रिनल कॉर्टेक्स पे काम करता है, and by acting at the zona glomerulosa of the adrenal cortex, they will be causing release of aldosterone. And you already know guys that whenever there is a release of aldosterone, this aldosterone is going to actually cause sodium and water retention. Rest of the thing is very very easy, that whenever there is sodium and water retention, this sodium and water retention will be causing increase in the blood volume, increase in the cardiac output, and ultimately they will also add on to increase in the ब्लड प्रेशर। तो ये भी बीपी को बढ़ा रहे हैं। तो अल्टीमेटली रास सिस्टम का मेन पर्पस क्या है? व्हाट इज द मेन एक्टिविटी, व्हाट इज द मेन एक्शन ऑफ द रास सिस्टम? सो द मेन एक्शन ऑफ द रास सिस्टम दैट वी नो, दे मेनली कॉज इंक्रीज इन द ब्लड प्रेशर। व्हेनेवर रास सिस्टम गेट एक्टिवेटेड, दे मेनली कॉज बीपी का एक्टिवेशन, बीपी को बढ़ा देते हैं ये। ठीक है, नाउ वन बाय वन लेट्स प्लॉट द ड्रग। लेट्स डू आवर फेवरेट वर्क दैट वी हैव बीन डूइंग सो फार। First and foremost, if I ask you guys that a question is going to ask that renin secretion inhibitor, there is a question called renin secretion inhibitor, and renin secretion inhibitor will be none other than any of the beta 1 blocker, because renin is secreted under the influence of the beta. But if the examiner is directly going to ask you renin inhibitor, so here the answer will change from beta blocker to aliskiren. The answer here is going to change to aliskiren. Okay, they are the renin inhibitor aliskiren. Then we have angiotensin 1 to angiotensin 2 conversion with the help of angiotensin converting enzyme, and this is going to be inhibited by captopril or any of the prils. Okay, ACE. So this is going to be april. All the ACE inhibitors, they were born in April, so all the ACE inhibitors, they end with pril. Example like your captopril, lisinopril, enalapril, ramipril, fosinopril, moxapril, perindopril, quinapril. The list is endless. Just remember, all the prils are ACE inhibitors. Okay. Now angiotensin 2 is going to act on the AT1, so we can also give a drug here that can block angiotensin 1. उसको हम बोलते हैं angiotensin receptor blockers. And angiotensin receptor blocker, they are all going to end with sartan. For example, sartans like your, let's say we have telmisartan, we have other sartans, losartan, valsartan, eprosartan, candisartan, all of them are sartans. They are the angiotensin receptor blocker. Then we are also having your aldosterone, right? Aldosterone that is released from the zona glomerulosa. We have some drug that can also target the aldosterone. So aldosterone receptor blockers are going to be drugs like your spironolactone, and other one is known as your eplerenone. Spironolactone and other one is known as your eplerenone. They are the aldosterone receptor blocker. Increase in the cardiac output because of sodium and water retention, that is increasing the BP. So we can also have some other drug, let's say diuretics, can target this area where sodium and water retention will be there. They will be causing flushing out of the excess fluid volume. Okay, so different area pe how to target how to give antihypertensive drug. We have studied that how different antihypertensive drugs are mainly working at the different sites. Okay, so we have covered this one. Now let's come back to our answer once again. It's very easy, that renin actually released because of beta 1, and that was the starting point of the RAAS system. So correct answer is going to be beta 1. I think all of you guys have got this one. M1 kahan pe? M1 is present on the gastric parietal cell, and they are going to cause increase in the acid release. M1 kahan pe hai? They are mainly present at the gastric parietal cell, causing your acid release. M2 that we have, they are mainly present on the heart. M2 is mainly present on the heart. ठीक है, M2 is mainly present on the heart. Beta 2 is present in many conditions. For example, beta 2 can be present on the lungs. Beta 2 can be present on the lungs. Beta 2 can also be present on the skeletal muscle. ठीक है, beta 2 is also present on the liver. ठीक है, at the lungs they are going to cause bronchodilation. Skeletal muscle pe they are going to cause tremor. At the lung they can cause gluconeogenesis and glycogenolysis, and therefore there will be increase in the level of glucose. And beta 2 can also present on the blood vessel. At the blood vessel they are going to cause vasodilation. So at multiple places beta 2 is present, and all their location and function, everything we have covered already in this question. I hope all of you guys have got the correct answer and the explanation of the other options as well. Next question is about a 44-year-old female presented with the complaints of xerostomia. What is xerostomia, guys? Xerostomia. What is xerostomia? There is something called xerophthalmus. Xero word, wherever we use, it is for the dryness. So xerophthalmia is for the dry eyes, but xerostomia is for the dryness of mouth. So in a patient with a Sjogren syndrome, actually there is going to be autoantibody against the glands, and because these are going to be the facial gland, autoantibody against the facial glands, there will be dryness of mouth, dryness of the eye, plus there will also be difficulty in swallowing. there is also going to be difficulty in swallowing. ठीक है, ड्राइनेस ऑफ माउथ, ड्राइनेस ऑफ आई, प्लस देयर इज गोइंग टू बी डिफिकल्टी इन swallowing. ऑटो एंटीबॉडी अगेंस्ट द ग्लैंड्स. नाउ ग्लैंड्स पे कौन सा रिसेप्टर होते हैं बच्चे? वी हैव M3 receptor on the glands. We are having M3 receptor that is present on the gland. Now if there is an auto antibody present against this gland, है ना, they will not allow the secretion. If there is no secretion, the patient will definitely have difficulty in swallowing, है ना, swallowing में difficulty होगा, है ना, saliva high नहीं. So in that case scenario, we make sure that for the management we should give M3 receptor agonist. The very selective specific M3 receptor agonist that we have is given the name as a cevimeline. Cevimeline is one of the specific M3 agonists that is working at the glands. This cevimeline is considered the drug of choice for xerostomia in Sjogren syndrome. Plus, other M3 agonists like bithanicol can also be used. Although we have other uses of bithanicol also, but as a drug bithanicol can also be utilized. Bithanicol को भी हम use कर सकते हैं, ठीक है. And we can also use other drugs like pilocarpine. As a matter of fact, any M3 agonist that we have, they can be utilized in this one. So pilocarpine mainly utilized in angle crochet glaucoma. But are they M3 agonists? Yes. Can we use them in xerostomia? Yes. है ना, तो इन सभी को यूज कर सकते हैं. बट एट्रोपिन तो M3 रिसेप्टर का एंटागोनिस्ट है ना, वी कैन नॉट यूज एंटागोनिस्ट, वी नीड टू यूज एगोनिस्ट. So cevimeline, pilocarpine both can be utilized. Cevimeline, pilocarpine both can be utilized. So correct answer for this question is going to be your A and C both. In a patient presented in casualty with tachycardia, hyperthermia and mydriasis. Tachycardia, hyperthermia and mydriasis. Now as soon as you hear this term, what's the diagnosis? There is also dryness of mouth. So everywhere secretion is reduced. Overdose of which of the following agent can cause this? Which of the following overdose can cause this condition, guys? बताइए. Organophosphate carbamate, atropine poisoning, opioid poisoning. Which one? Hi everyone. Okay, atropine. Okay, overdose of which of the following can cause this? Atropine. Okay, 1 student, 2 student, 3 student. Okay, so C is the correct answer that you have given. Always remember, guys, that as soon as you hear this kind of question, the next differential diagnosis that comes to our mind is always and always going to be organophosphate carbamate and atropine. They are always very commonly asked question, and their symptoms are actually poles apart. For example, if there is going to be atropine poisoning, I always write atropine as atopine, है ना. atropine को मैं लिखता हूँ atopine. atopine का मतलब everything is on the top. atropine poisoning, everything is on the top. atopine मतलब देखिएगा top, आंखों से स्टार्ट करिए, है ना. I always say that eyes never lies. आंखें कभी झूठ नहीं बोलती हैं, ठीक है. आप आंखों में देखिए, आपको पता चल जाएगा. तो एटोपिन आंखें टॉप पे, आंखें टॉप पे मतलब देयर इज गोइंग टू बी माइड्रियासिस, है ना, बिकॉज M3 इज ब्लॉक्ड, पैसिव माइड्रियासिस होगा. आईज नेवर लाइज. ओके, नेक्स्ट. इफ यू कम डाउन अ लिटिल मोर डाउन, आप बोलिए कि ओपन योर माउथ, यू विल सी देयर विल बी डिक्रीज्ड सिक्रीशन कम होगा, और बॉडी का भी सिक्रीशन कम होगा. Because of it, the body temperature is also going to be high. So again, atopine, pupil size top पे है, body temperature top पे है. Go a little more down to the heart rate. Heart rate will also be high. Heart rate is also going to be high. So everything is going to be on the top. हर चीज़ क्या है, top पे है. Mydriasis, body temperature, heart rate. Because they are non-selective M3 antagonists, everything is seen here. The antidote or the treatment for this one is going to be, a specific antidote is going to be physostigmine. Physostigmine is the specific antidote for atropine poisoning. And a close differential that I was telling you is carbamate and organophosphate. Why am I telling close? Because although they are not close, they are poles apart. दोनों का symptom exact opposite होता है. So organophosphate carbamate, what are these? These are actually irreversible acetylcholine esterase inhibitor. They are ultimately going to increase the level of acetylcholine, irreversible acetylcholine esterase inhibitor, increasing the level of acetylcholine. Now, if there is increase in the level of acetylcholine, what will happen? Too much acetylcholine in the eye, there will be miosis. Too much miosis can often given the name as a pinpoint pupil. Pinpoint pupil. Overall, the body temperature may be lesser because the too much secretion, the body temperature may be normal to lesser, है ना, due to secretion is very high. So इसमें too much secretion because glandular secretion is high. M3 receptor is causing too much glandular secretion. You go to the heart, you will find the heart rate is also going to be lesser. Heart rate is also going to be lesser. So eyes never lies. आंखें देखिए, आंखें छोटी हैं. Most likely it will be a case of organophosphate carbamate. So if there is a history of farmer, most likely it will be a case of organophosphate carbamate, because there is something also called that is opioid poisoning. Opioid. Now remember opioid. It can also cause pinpoint pupil. In the toxic dose, they can also cause pinpoint pupil. Okay, agreed. Now always remember, whenever they ask you opioid poisoning, they will be associated with a history of drug addict. So if there is a history of drug addict coming with the pinpoint pupil, most likely it will be a case of your opioid poisoning, pinpoint pupil. ठीक है, associated with the drug addict का history, है ना. They can also have a decrease in the blood pressure, decrease in the heart rate, decrease in the BP, decrease in the heart rate. Some of the symptoms are pretty much similar to organophosphate carbamate. Remember this one, है ना. इसके स्पेसिफिक एंटीडोट्स भी चेंज होंगे. ऑर्गेनोफॉस्फेट कार्बामेट का स्पेसिफिक एंटीडोट इज गोइंग टू बी एट्रोपिन. However, oxime can also be utilized. Oxime can be utilized in organophosphate poisoning. And in opioid poisoning, the specific antidote that we have is given the name as a naloxone. ठीक है, naloxone. So these are the three important topic that is frequently going to be asked for all of you guys, and you should always keep in mind the details that we have discussed here in these topics. You can always have question on this topic, very frequently asked topic. ठीक है, क्या हो रहा है? चलो छोड़ दो इसको ऐसे ही. Right, so you already have the answer to this question. I believe that it's going to be atropine, and why it is not opioid, and why the patient is not having organophosphate carbamate as an answer, because they are having more and more cholinergic symptom will be seen. ठीक है, हाँ जी, है ना. तो रेस्ट एंड डाइजेस्ट तो मेनली उसका होता है ना डॉक्टर, पैरासिम्पैथेटिक रेस्ट एंड डाइजेस्ट. ठीक है, fight or flight response emergency में it is always going to be sympathetic. Next is about a 26-year-old female that is presenting with a complaint of ptosis and generalized weakness. This is not weakness, सब साथ में weakness, both of which worsens as the day progresses. So the differential possible diagnosis that we are having here is going to be myasthenia gravis. Which of the following can be used to screen? So myasthenia gravis में एक ड्रग होता है जिसको बोलते हैं एड्रोफोनियम. एड्रोफोनियम इज अवेलेबल इन द मार्केट बाय द नेम ऑफ टेंसिलॉन, एंड टेंसिलॉन इसीलिए इसका नाम ही पड़ा है टेंसिलॉन टेस्ट. द नेम इज नोन एज योर टेंसिलॉन टेस्ट. So this is a very short acting reversible acetylcholine esterase inhibitor. They are very short acting reversible acetylcholine esterase inhibitor, and once you inject adrophonium, very low dose, and injection of adrophonium, and after injection, let's say you are going to inject 1 to 2 milligram IV, 1 to 2 milligram IV. Once you inject, if the symptom is improved, that means the autoantibodies were mainly occupying the site, and after giving adrophonium, they are reversible acetylcholinesterase inhibitor. They can always increase the level of acetylcholine. So symptom improve, that means most likely is case of myasthenia gravis. Now the problem is, be it a case of myasthenia gravis, be it a case of cholinergic crisis, दोनों एक जैसे present होते हैं. Both have similar kind of weakness, because too much of acetylcholine is also going to be problematic. When you give adrophonium, the level of acetylcholine will increase, and this can lead to symptom ka worsening. So if the symptom worsens out, this will be most likely a case of cholinergic crisis. So इस पूरे all test को हम बोलते हैं tensilon test, because this is available in the market by the name of tensilon. ठीक है. So which of the following agent can be used to screen the condition? The name of the drug is going to be your adrophonium. However, for the myasthenia gravis, if the next exam question is examiner is going to ask you question that what is the treatment, what is the drug of choice, what is the treatment, what is the drug of choice? Remember, for the myasthenia gravis, we can use, usually I used to tell them, remember PAN, myasthenia gravis, PAN, that is going to be drugs like your pyridostigmine. Because of the lesser side effect and longer T half-life, they are considered the drug of choice. Other agent that we have is known as your ambenonium, pyridostigmine, ambenonium, and we have the next that is known as your neostigmine. So this is known as your PAN, PAN. Pyridostigmine, ambenonium, neostigmine, these are the drugs that can be utilized in myasthenia gravis का management में, drug of choice being the pyridostigmine. ठीक है. What is rivastigmine, guys? Rivastigmine, and rivastigmine, it's a drug that is also a tertiary amine under reversible acetylcholinesterase inhibitor. It is mainly utilized in Alzheimer's disease. It's available also by the transdermal patch. So in 2023, this question was asked: a patient is not able to tolerate oral drug. Which of the following drug will be utilized in this patient? है ना. तो they give a history of Parkinson वाला, या patient having है ना recurrent forgetfulness, और ये वाला history दिया हुआ था. Basically, it was a clear cut case of Alzheimer's disease, and they asked that which of the following drug will be given if the patient is not able to tolerate oral. ठीक है. Physostigmine is the antidote of atropine poisoning that I have told you already. Next is, a 55-year-old patient is presented with the history of diabetes and BP is 140/90. Which of the following antihypertensive drug would you avoid to prescribe? क्या avoid करोगे? What will you avoid to prescribe? Tell me, guys. What will you avoid to prescribe? Go ahead, please. What are you going to avoid to prescribe in this patient? क्या अवॉइड करेंगे? Hello, are you guys listening to me? Reply. Some of you are saying C, some of you are saying B, some of you are saying A. Okay, C, B, A. All right. So this is a case of diabetes, and he is already having a high blood pressure. So if there is a diabetic patient, always remember he must be taking some anti-diabetic drug. So in any diabetic patient on the oral hypoglycemic agent, one important problem, one important side effect that is always and always feared, or a feared side effect that we always know, will be your hypoglycemia. Any diabetic patient will have this side effect called your hypoglycemia. Hypoglycemia itself is an emergency condition. Whenever there is a hypoglycemia is an emergency. In emergency, I told you fight or flight response activate hota hai. There will be activation of fight and flight response. So there is going to cause sympathetic symptom ka activation. Sympathetic symptom ka activation का मतलब क्या हुआ? Whenever there is sympathetic system का activation, they will be causing activation of certain activities का, certain receptor का activation. For example, there will be beta 1 activity that can lead to tachycardia. It can also lead to palpitation, tachycardia, palpitation. They can also cause activation of beta 2 at the skeletal muscle, and at the skeletal muscle they can lead to tremor. The skeletal muscle pe they can lead to what? Tremor. Then your sweat gland is also under control of sympathetic, because we know sweat gland is sympathetic and cholinergic in nature. So sweat gland will get stimulated and they will be causing increase in the sweating. Sweat gland is sympathetic and cholinergic in nature. That means they will get activated by the sympathetic drive, but the secretion of acetylcholine is acetylcholine mediated, right? So there will be sweating as well. So we are having tachycardia, palpitation, tremor, and there will be sweating as well. Okay, so in this patient, always remember all these symptoms that we are seeing: sweating, tremor, palpitation, tachycardia, sweating, tremor, all these, इनको हम बोलते हैं warning symptom of hypoglycemia. What do we call them? We are always going to call them warning symptom of hypoglycemia. We are going to call them warning symptom of hypoglycemia. So whenever there is any patient on anti-diabetic drug or patient on insulin, they always have a feared complication, a feared side effect that we can always be afraid of, that there can be always hypoglycemia. That is why we always say that you keep something sweet with you or eat something sweet if you get this kind of symptom. So whenever they get this kind of symptom, remember the liver of the body will get the signal. Because liver के भी पास क्या है, हमारे पास लिवर के पास भी क्या है, बीटा 2. They will say, liver, where are you sleeping? The body is going into hypoglycemic shock, है ना? Please take action here. So liver will cause gluconeogenesis because metabolic function is also under the autonomic control. So there will be gluconeogenesis and there will also be glycogenolysis. Because of the gluconeogenesis and glycogenolysis, there is actually going to be increase in the plasma glucose. Whenever there is any increase in the plasma glucose that is occurring in response to hypoglycemia, this can actually lead to reversal of hypoglycemia. ये क्या करेगा? ये क्या किया यहाँ पे? There will be reversal of hypoglycemia. So whenever there is any emergency like hypoglycemia, the body is responding in itself. There is increase in the sympathetic drive, and that is going to give rise to warning symptom of the hypoglycemia. They are going to give rise to warning symptom of the hypoglycemia. Whenever there is a warning symptom of hypoglycemia, they can also lead to reversal of the hypoglycemia after some time. They can also lead to reversal of hypoglycemia after some time. But imagine if this patient takes beta blocker, or any physician prescribes him beta blocker without taking complete history, the beta 1, beta 2 is blocked. In presence of beta blocker, do you think this patient will have warning symptom? क्या आपको लगता है warning symptom आएगा? सोचिए, बताइए. Do you think warning symptom will come? No. So always remember, if beta blocker is added to this one, the patient will have no warning symptom of hypoglycemia. So this patient can actually go to hypoglycemic shock or hypoglycemic coma without showing any symptom. This patient can go into hypoglycemic shock or coma without showing any symptoms. So that will be no warning symptoms. Apart from that, if you are blocking beta, don't you think you will be blocking of the liver as well? Yes, liver का भी beta को block करोगे, है ना? So again, warning symptom भी नहीं आएगा, and there will be no reversal of hypoglycemia also. There will be no reversal of hypoglycemia. So you see, there will be no warning symptom and there will be no reversal of hypoglycemia if you add any beta blocker. Therefore, which drug is mandatorily contraindicated in a diabetic patient, especially that is going to be your beta blocker, especially non-selective beta blocker. And here no warning symptom, एक warning symptom तो आएगा, that is known as your sweating, except your sweating. So sweating will be the only reliable symptom in a diabetic patient on oral hypoglycemic agent and whenever there is a hypoglycemia. Okay, so sweating is the only warning symptom that will be seen because sweating is sympathetic and cholinergic in nature. ठीक है, अब आपका सवाल काफी क्लियर हो गया. ACE inhibitor तो प्रिफर करते हैं यार, ACE inhibitor ARB, they are the preferred antihypertensive drug in a diabetic patients. In fact, telmisartan, it is having additional PPAR gamma agonistic property, peroxisome proliferator activated receptor gamma, and because of the PPAR gamma, peroxisome proliferator activated receptor gamma agonistic property, they also increase the insulin sensitivity. तो ये तो सबसे preferred drug है diabetes के लिए. long-term diabetic patients, sometimes even without hypertension, we use ACE inhibitors. Amlodipine ka there is no such contraindication in diabetes, but I just told you that beta blocker should not be given, and two reasons that I told you. One is they will mask the hypoglycemic symptom or warning symptom of hypoglycemia, and they will also not allow the reversal of the hypoglycemia. Okay. So I hope all of you guys have got this one, and we can talk about the next question now. Which of the following drug causes maximum increase in the heart rate? Epinephrine का action is seen on the alpha 1, alpha 2, beta 1, beta 2, beta 3. So if this is the heart rate wala graph, because of the beta 1 activity, epinephrine will increase the heart rate. इसमें कोई doubt नहीं है. ठीक है. Heart rate graph. So this is going on the upper side, this is going on the lower side. Alpha 1, alpha 2, beta 1, beta 2, beta 3. So beta 1 activity will cause increase in the heart rate. Norepinephrine, they act on alpha 1, alpha 2, beta 1. They do not have any beta 2 activity. Because there is no beta 2 activity, just remember, because there is no beta 2 activity, this alpha 1 activity is going to be unopposed. Alpha 1 activity is going to be what? Unopposed. Unopposed alpha 1 activity is going to cause too much of the vasoconstriction. Too much of the vasoconstriction will increase the diastolic blood pressure. And one thing that we have learned from our physiology, that whenever diastolic blood pressure is high, this will be sensed by the baroreceptor, and they will be sending the signal to the brain that brain, I am getting too much pressure, help me out. In response to this, brain will be increasing the vagal tone. Vagus stimulation will increase, and because of this, they can actually lead to increase के बजाय decrease in the heart rate. So the only drug that we have in the autonomic nervous system that is causing decrease in the heart rate, this is not direct, this is occurring in response to brain's activity. So इसको हम बोलते हैं reflex bradycardia. So norepinephrine will always be causing a reflex bradycardia. Therefore heart rate का graph is going to be on the lesser side. ये नीचे की तरफ जाएगा heart rate का graph, ध्यान रखिएगा. Heart rate graph will go towards the नीचे का side. So this will be possibly your norepinephrine. ऊपर वाला possibly will be your epinephrine. Now let's talk about isoprenaline. Isoprenaline has an isolated action on the beta 1 and beta 2. Isoprenaline has an isolated action on beta 1 and beta 2. Okay. Now, especially with respect to blood pressure, if I talk, beta 2 is going to cause vasodilatation. Yes or no? Beta 2 will be causing vasodilatation. Any vasodilatation will cause a decrease in the diastolic blood pressure. Beta 1 activity will directly increase the heart rate. It's obvious, it's very obvious that beta 1 activity is directly going to increase the heart rate. We do not have any doubt in this. But because of the diastolic blood pressure fall, don't you think this will also be sensed by the brain? Don't you think this will also be sensed by the brain? Brain हर चीज को baroreceptor sense करेगा, and baroreceptor will be sending the signal to the brain. ये मान लीजिए यहाँ पे कैरोटिड है, तो baroreceptor they are going to send the signal to the brain that I am getting more pressure or less pressure, जो भी pressure difference आएगा. In response to this, what will brain give rise? Brain will increase the sympathetic tone, and when the sympathetic tone will increase, once again the heart rate will be high. The heart rate will go high according to the same strength of the diastolic blood pressure. If the diastolic blood pressure is much lesser, the heart rate or reflex heart rate will also be coming in the same strength. ठीक है, the heart rate will be coming in the same strength, है ना. तो heart rate यहाँ पे भी बढ़ जाएगा. तो एक देखिए direct heart rate भी बढ़ रहा है, reflex heart rate भी बढ़ रहा है. So direct या indirect, both of them are causing increase in the heart rate, and therefore isoprenaline का graph whenever you see, they will have maximum increase in the heart rate. So dugna heart rate, almost maximum increase in the heart rate. Dugna I have shown you just to make you understand that isoprenaline will have maximum increase in the heart rate. Epinephrine or dopamine can cause increase in the heart rate undoubtedly, but norepinephrine will be causing reflex bradycardia. The answer to this question, examiner is asking maximum increase in the heart rate. So you already know guys, the maximum increase in the heart rate is noted with your isoprenylene. I hope all of you guys have got this one. डोपामीन का जो एक्शन होता है, दिस इज सीन यूजुअली अकॉर्डिंग टू डोज. सो डोपामीन एक्शन इज मेनली सीन अकॉर्डिंग टू डोज, इसीलिए उसको बोलते हैं कि देयर एक्शन इज डोज डिपेंडेंट. They are having mainly dose dependent action, and the dose dependent action is seen mainly on the dabba. So it is, I always call them very fondly dabba because they are working mainly on the D1, beta 1 and alpha 1. I'm always going to call them dabba because they are working on the D1, beta 1 and alpha 1. Dabba is a very very simple mnemonic where dopamine is working. D1, beta 1, alpha 1 stand for D1 in any dose less than 2 microgram per kg per minute. D1 will be stimulated. In a dose of 2 to 10 microgram per kg per minute, B1 will be stimulated, and alpha 1, any dose more than 10 microgram per kg per minute, alpha 1 will be stimulated. So D1, beta 1 and alpha 1, they are going to cause stimulation of stimulated by dopamine. So dopamine का action dose dependent होता है. So whenever they are working in the low dose, they will be causing vasodilation. At the intermediate dose beta 1 पे, they are going to cause inotropic support, and they can also increase the heart rate. Inotropic support, and they can also increase the heart rate. And beta 1 पे, because of the vasoconstriction, they can increase the blood pressure as well. This is why whenever there is any patient shock with oliguria with unrecordable BP, the drug that we are going to prefer is going to be your dopamine. The drug that we are going to prefer is dopamine. Dose, I have also already mentioned that which dose of dopamine you are going to use. In this case scenario, the dose will be the highest wala dose. Okay? So every option here has been framed. Which of the following drug doesn't cause SLE like symptom? SLE is systemic lupus erythematosus. You guys can give me the answer already. I see very less people are responding. बताइए प्लीज. Hi guys. Which of the following drug doesn't cause SLE-like syndrome? SLE-like symptom, SLE-like syndrome. So SLE-like symptom will be caused by any drug that is actually going to get metabolized by acetylation. Any drug metabolized by acetylation, and the drugs metabolized by acetylation, and the enzyme that is required is N-acetyltransferase. N-acetyltransferase. And the example of a drug that is metabolized by acetylation is remembered by the mnemonic SHIP drugs. इनको हम SHIP drugs के mnemonic से याद रखते हैं. तो SHIP drug stand for your sulfonamide. All the sulfonamide including dapsone, because dapsone is also sulfonamide. Hydralazine, one of the potassium channel opener. Isoniazid, a first line antitubercular drug. And next one is going to be procainamide. What is procainamide, guys? It is one of the class 1A antiarrhythmic drug. Class 1A antiarrhythmic drugs. So all these drugs are getting metabolized by acetylation. There are other drugs also in the list. If you see your Katzen ka recent edition, they have also mentioned about the drugs like your clonazepam, है ना? Other antitubercular drug like para-amino salicylic acid, है ना, एसीब्यूटोलॉल, कुछ अदर ड्रग्स का भी नाम उसमें है, बट मेनली आपको इन चारों का अगर आप याद रखते हैं तो यू विल बी एबल टू क्रैक ऑल द क्वेश्चन ऑन द ड्रग्स मेटाबोलाइज्ड बाय एसिटाइलेशन, है ना. सो सल्फोनामाइड, हाइड्रोलाजिन, आइसोनाइजिड तो है, बट पेनिसिलिन नहीं है ना. पेनिसिलिन इज नॉट दैट. पेनिसिलिन इज यूजुअली, है ना, नॉट मेटाबोलाइज्ड बाय एसिटाइलेशन. अ पेशेंट ऑन MAO inhibitor started to develop dizziness, palpitation, blood pressure is very high, that is going into the hypertensive crisis scenario after breakfast. Okay, MAO inhibitor के बाद अगर एक हिस्ट्री आता है कि पेशेंट ate something and now he is having increase in the blood pressure, Most likely this will be a case of cheese reaction. Now look at the option, look at the rest part of the history. Relatives state that it was a light breakfast containing banana and other fruit and some milk product. Which of the following is the most preferred agent in this scenario? Okay, क्या खाया? मिल्क प्रोडक्ट खाया, कुछ फ्रूट भी खाया, ठीक है, बनाना, ठीक है. Now this much is more than enough, because in your examination there may not be any vegetarian examiner, there may be a history of wine, because this cheese reaction is mainly seen, in patient those who are on MAO inhibitor upon intake of tyramine rich food, upon intake of tyramine rich food. अगर पेशेंट टायरामीन रिच फूड के बाद से माओ इनहिबिटर ले लेता है तो उसको प्रॉब्लम होगा. लेट्स अंडरस्टैंड व्हाई एंड हाउ. व्हाट आर द टायरामीन रिच फूड का एग्जांपल ऑफ टायरामीन रिच फूड कुड बी अ वेरी गुड एग्जांपल बी चीज इटसेल्फ, चीज, मिल्क और एनी अदर मिल्क प्रोडक्ट, मिल्क या मिल्क से बना कुछ भी, लाइक फॉर एग्जांपल इवन स्वीट्स दैट आर मेड ऑफ मिल्क, है ना, स्वीट्स दैट आर मेड ऑफ मिल्क, बीफ, बनाना, ठीक है, चीज, मिल्क और मिल्क प्रोडक्ट, बीफ और बनाना, इन सब में देर इज हाई अमाउंट ऑफ टायरामीन. नाउ व्हाट इज टायरामीन? रिमेंबर व्हाट इज टायरामीन? It is an agent that is acting by displacement reaction. Tyramine is an agent that is acting by the displacement reaction. Meaning of displacement reaction is tyramine will displace the noradrenaline from the synaptic vesicle. So for example, if this is, let us say, synaptic vesicle, and in this synaptic vesicle all these are noradrenaline, then tyramine, they are having displacement property. Whenever this tyramine is given, they can enter inside, they will take the place inside the vesicle and they will kick out the noradrenaline. Same amount of noradrenaline will immediately be kicked out from inside to outside. So suddenly there is going to be increase in the sympathetic tone because noradrenaline is going to be high suddenly. So tyramine is the one that is having sympathomimetic property, and whenever we are consuming any tyramine rich food, imagine this is our gut that we have. If ever we are consuming any tyramine rich food, beef, banana, cheese, milk, any sweets, बार बार हम sweets खाते रहते हैं, है ना, any product that we are going to eat, we always going to thank our gut because they are having abundance of an enzyme called monoamine oxidase, and this monoamine oxidase enzyme, they are going to cause a rapid breakdown or metabolism of this tyramine. इस tyramine को क्या करते हैं, वो immediately metabolize कर देते हैं. Tyramine is immediately getting broken down. Clear है? But if this patient is going to be on MAO inhibitor, अगर मान लीजिए ये patient पहले से ही MAO inhibitor ले रहा हो, then क्या होगा? If he is taking some drugs like MAO inhibitor, example of drugs like your selegiline, rasagiline, safinamide, these are all considered as a MAO B inhibitor. किसी तरह के माओ हो सकते हैं, सेलेक्टिव, नॉन सेलेक्टिव. सो दे आर सेलेक्टिव माओ बी इनहिबिटर दैट यू रिमेंबर बाई मेरा बेटा. माओ बी साउंड लाइक अ मेरा बेटा, एक मेरा बेटा है, मेरा बेटा शेरा जैसा. मेरा बेटा किसके जैसा? शेरा के जैसा. व्हाट इज शेरा जैसा? सेलेजिलीन, रेसाजिलीन, सफीनामाइड. सो इफ द पेशेंट कंज्यूम एनी ऑफ द माओ इनहिबिटर, what will happen to the tyramine, guys? This tyramine will not be metabolized and this tyramine is going to be apparently high inside the our body, and more tyramine, that means more sympathetic like symptom. More tyramine means more sympathetic like symptom, and that is why to avoid this kind of problem we always say that do not consume any milk or milk related meal, है ना, कोई milk related meal मत लीजिए जिसमें milk product पड़ा हो, ठीक है. तो because of the increased amount of tyramine there will be hypertensive crisis like scenario can be seen, and the management for this one, or as a drug of choice, we always use a drug by the name of phentolamine. Phentolamine is a non-selective alpha blocker. It's a non-selective alpha blocker, that is a drug of choice for cheese reaction. Drug of choice for cheese reaction. So cheese reaction usually hypertensive crisis like situation हो जाता है. So which of the following is the most preferred agent? I think all of you guys have got this one. The drug of choice is going to be phentolamine. Atropine is a non-selective muscarinic antagonist used in organophosphate carbamate poisoning. Epinephrine for shock-like scenario like let's say anaphylactic shock, and dopamine has multiple uses because they are working on different receptor called DABA. Next question is about a 55-year-old male presented with complaints of inability to evacuate the whole bladder. Okay, so inability to evacuate the whole bladder, I think you can easily guess this scenario. This is actually going to be a case of benign prostatic hypertrophy, but this is not it. The BP is 140/80, so benign prostatic hypertrophy with hypertension. Plus there is impaired lipid profile and other things are also given. So in this case scenario, guys, remember impaired lipid profile and all. Remember the drug of choice for BPH with hypertension. The drug of choice is always going to be your alpha 1 blocker. Alpha 1 blocker, like any drug like your prazosin, terrazocin, elfusocin, bunazocin. The name is all going to end with the zocin. The name is all going to end with the zocin. But if there is only going to be a case of benign prostatic hypertrophy, the drug of choice will be super selective alpha 1A blocker, and the name of this drug is going to be tamsulosin, and other one is going to be silodosin. Tamsulosin and silodosin, they are the selective alpha 1A blocker. What is the advantage of this tamsulosin, silodosin over the previous drug? The advantage of tamsulosin over the prazosin that we have, they actually do not cause postural hypertension. They actually do not cause postural hypertension because prazosin तो बहुत ज़्यादा postural hypertension कराता है. Postural hypertension risk will be very high with the prazosin. So in this case scenario, because there is the impaired lipid profile, remember they have shown to have improved lipid profile as well, and they also improve the carbohydrate metabolism. They have shown to decrease the LDL and increase the HDL level, and they are also going to increase the carbs ka metabolism. That is why in diabetics and dyslipidemic patient also we can prefer them. So correct answer for this one is going to be prazosin. It is also considered the drug of choice in a patient with a scorpion bite, which was asked in the recent examination. Usme bhi again prazosin or any of the alpha 1 blocker can be seen. Okay. Now there is already inability to evacuate the whole bladder, so risk of urine retention is already very high. If you are going to use a drug like mirabegron, which is a beta 3 agonist, derifenacin, which is a M3 antagonist, they share a similar kind of activity. What do I mean by similar kind of activity? Imagine if this is the bladder. This class of drug, mirabegron, derifenacin, they actually cause relaxation because derifenacin is a sympathetic and derifenacin is M3 antagonist and mirabegron is sympathetic agonist and beta 3 agonist. So they both can actually cause relaxation of the bladder. So urine holding capacity of the bladder is actually going to increase, and when the urine holding capacity of the bladder is actually going to increase, what will happen? The risk of urine retention will be further high. So इस patient को treat करने के बजाय if you use mirabegron or derifenacin, you will worsen the scenario. Tamsulosin can be used, yes, but again, which of the following drug is preferred? Examiner is asking. So if there is already hypertension plus BPH, we are going to prefer prazosin rather than tamsulosin. Tamsulosin only if there is a history of BPH. Only BPH में tamsulosin. Let's see the next one. In a patient with a chronic congestive heart failure, a beta blocker was started having additional vasodilating property by releasing nitric oxide. So beta blocker, third generation beta blocker, that is causing nitric oxide release. So इसको मैं याद करने के लिए सिंपल तरीका बोलता हूँ कि नाइट्रिक ऑक्साइड N से नाइट्रिक ऑक्साइड होता है. Remember, there is a new channel by the name of CNN nitric oxide, CNN nitric oxide. So nitric oxide is mainly causing vasodilatation. Okay, so CNN is a news channel that also dilates all the news. सारे news को बड़ा कर देता है कौन? CNN news channel है ना. So we have a drug that is celiprolol. We have a drug that is your nebivolol, and we also have a drug by the name of your nipradilol. So CNN is a new channel that is having beta blocking property. In addition to beta blocking property, they are also having nitric oxide releasing property. इसमें celiprolol cardioselective beta blocker with the nitric oxide release. Nebivolol is also a cardioselective beta blocker. The most cardioselective beta blocker is nebivolol. Examiner is asking, all of the following beta blocker has this property except. बहुत आसान हो गया अब मैंने 3 दे दिया, nebivolol, nipradilol, celiprolol. You all have to select labetalol because labetalol, it can cause vasodilatation, yes, but not by releasing nitric oxide. They are actually beta blocker with alpha 1 blocking property. Labetalol as a drug, they are considered the drug of choice for hypertension and hypertensive emergency in pregnancy. Hypertension and hypertensive emergency in pregnancy, the drug of choice is going to be none other than your labetalol. ठीक है. So I hope all of you guys have got this one. ठीक है. Many of you marked B as an answer here, but B is not the correct answer. Labetalol, it can cause vasodilatation, but not by nitric oxide releasing. They will be causing vasodilatation mainly by your alpha 1 blockade. Vasomotor reversal of Dale is, how will you elicit vasomotor reversal of Dale? First and foremost, for you to understand vasomotor reversal of Dale, we have to understand the normal response of epinephrine in any normal person. Normally, if I am going to use epinephrine, what is the normal response? Does it cause only increase in the blood pressure, only decrease in the blood pressure, or it has dual activity? Because we know that epinephrine as a compound, it acts on every receptor of the sympathetic nervous system. Epinephrine is going to act on the alpha 1 receptor, alpha 2 receptor, beta 1 receptor, beta 2 receptor, and they can also work on the beta 3. They will be acting on every receptor. Hello, yes. If they are working on every receptor, so let's talk about blood pressure. There is a patient coming, or in an experimental setting, let's say you are having a normal blood pressure of 120, and if you are going to introduce a high dose of epinephrine in this case scenario, so because they are working on all receptor, but there is a small catch here, that beta 2 happens to be the most sensitive receptor. Beta 2 happens to be the most sensitive receptor. What is the meaning of most sensitive receptor? That they will be responding at a lesser dose. They are going to respond at a lesser dose. ये lesser dose, कम dose पे काम करना शुरू कर देते हैं. They will be working or showing predominant action at the lesser dose. But alpha 1 receptor that we are having, they are going to be more in number. ये नंबर में ज़्यादा है. सो दे ऑलवेज शो प्रिडोमिनेंट एक्शन इनिशियली. कभी भी जब हम नॉरेड्रेलिन देते हैं, सो दे विल ऑलवेज एंड ऑलवेज शो प्रिडोमिनेंट एक्शन. वाई? Because they are more in number. So it's like this. Let's say we are sitting in this classroom, and in this classroom we are having 100 students. Let's say 80 boys and 20 girls. Okay? Now if I am going to throw, let's say around 50 to 60 candies or chocolate, and if I ask who will have more chance of grabbing the chocolate, boys or girls? So because boys का number ज़्यादा है, boys will automatically be having more chocolate. Likewise, if epinephrine will be exposed, there is a beta, there is alpha. So boys, the alpha male, beta 2, girls, the sensitive one. So sensitive one will have, they will be responding at the lesser dose. But whenever it is given initially, alpha 1 will take more amount of neurotransmitter, they will be causing predominant action. So because of the predominant action of the alpha, whenever epinephrine is given alone, what will happen? They are going to cause increase in the blood pressure. So because of the alpha 1 mediated, there will be increase in the blood pressure. Alpha 1 mediated increase in the blood pressure. So this BP will go from 120 to let's say 160 or 170 mmHg. BP बढ़ गया. Now, when the drug concentration is going to come down at the lesser plasma concentration, At the lesser plasma concentration, I told you which receptor will be stimulated, guys. I told you come plasma concentration, beta 2 will be stimulated, and because of the beta 2 stimulation, the BP will further fall down. So this can go back to, let's say, till 90 mmHg, and once the drug is completely washed out, they will go back again to the normal 120 वाले पे चला जाएगा. So whenever we give epinephrine, if I ask you what is the normal response of epinephrine, so you see epinephrine is having biphasic response. Am I correct? Yes or no? They are having biphasic response. Definitely yes. What is the meaning of biphasic response? Because alpha 1 is having strong action, predominant action. First there is going to be increase in the blood pressure, and then there is going to be decrease in the blood pressure. पहले बढ़ेगा फिर घटेगा, पहले बढ़ेगा फिर घटेगा. Because examiner asks you that epinephrine effect on the blood pressure, only increase, only decrease, first decrease then increase, then decrease, increase then decrease, ऐसे करके चार ऑप्शन आएगा. Now ये तो हो गया normal. But if you are going to do the experiment that is done by Henry Dale Saab, that is Vasomotor reversal of Dale. So how this experiment was done? This experiment was done when in presence of alpha blocker, you gave high dose of epinephrine. So you will be seeing only reversal of BP will be seen. Let's understand this concept. Alpha blocker के presence में epinephrine दिया, ठीक है? So alpha blocker drugs like, let's say, prazosin, terazosin, they are all the drugs that is used in many conditions. One of the condition is also hypertension. So hypothetically speaking, that मान लीजिए इस patient को hypertension था, and this patient he consume alpha blocker. तो alpha blocker के presence में what will happen to the blood pressure, guys? Alpha blocker के presence में मान लीजिए alpha blocker उसने सुबह ले लिया, prazosin, terazosin कोई भी alpha blocker था, he has consumed this, and the blood pressure because of this is absolutely normal. पहले एक नॉर्मल सिनेरियो था, एंड दिस इज गोइंग टू बी ऑलरेडी अ केस जहाँ पे ऑलरेडी टू मच कैटेकोलामीन था, एंड वहाँ पे हमने एक अल्फा ब्लॉकर दिया, तो बीपी नॉर्मलाइज हो गया. नाउ वंस द बीपी इज नॉर्मलाइज, एंड एट दिस पॉइंट ऑफ टाइम यू आर गोइंग टू एक्सपोज योर पेशेंट ऑन हाई डोज ऑफ एपिनेफ्रीन. हाई डोज ऑफ एपिनेफ्रीन पे जब एक्सपोज करोगे तो होता क्या है, व्हाट विल हैपन, यू अंडरस्टैंड एंड यू नो ऑलरेडी दैट नाउ दे आर एक्चुअली going to cause increase in the blood pressure. Ideally तो ऐसे था ना, एपिनेफ्रिन दिया तो फर्स्ट इंक्रीज देन डिक्रीज देन दे आर गोइंग टू गो बैक टू द नॉर्मल, बट इट विल नॉट हैपन हियर. व्हाई? बिकॉज अल्फा रिसेप्टर्स तो ब्लॉक्ड हैं. वी सी हियर यू जस्ट ब्लॉक्ड योर अल्फा रिसेप्टर दिस मॉर्निंग, एंड नाउ इफ यू आर गोइंग टू एक्सपोज हाई डोज ऑफ एपिनेफ्रिन, हाउ डू यू expect this alpha receptor to work, act? How do you expect the BP to increase? No, it is not going to happen. It's not फन, मजाक थोड़ी है ना, बढ़ेगा नहीं. सो बीपी विल ट्राई टू गो अप बट इट कैन नॉट गो अप. व्हाई? बिकॉज अल्फा रिसेप्टर्स आर ब्लॉक्ड. सो व्हाट इज द रेस्पॉन्स दैट वी आर गोइंग टू सी? ऑल द एपिनेफ्रिन विल नाउ बी वर्किंग ऑन द बीटा, एंड वंस द ड्रग विल बी completely washed out, they will go back again to the normal. So again the BP can go to further down, let's say 90 और नीचे जा सकता है, 80 पे चला गया, ठीक है, the BP will go to further down, है ना. So there is going to be only fall in the blood pressure that is due to beta 2 mediated, and this response of alpha blocker के presence में when I give high dose of epinephrine, we see there is only reversal of BP, there is only going to be fall in the blood pressure. इसी particular response को हम बोलते हैं vasomotor reversal of Dale. Vasomotor reversal of Dale. Now अगर beta 1 activate होगा, so they can even lead to tachycardia, palpitation. That explains the fact that why in a patient with the pheochromocytoma, PCMA is a pheochromocytoma which is having one of the adrenal medulla tumor. What is pheochromocytoma, guys? It is one of the adrenal medulla tumor. In a patient with the pheochromocytoma, that is one of the adrenal medulla tumor, there is a tumor coming, and this is causing more and more release of catecholamines. Because of this catecholamine is going to act on the alpha receptor also, beta receptor also. आप सब समझ सकते हैं. कैटेकोलामिन्स लाइक एपिनेफ्रिन, नॉरएपिनेफ्रिन, दे विल बी एक्टिंग ऑन बोथ अल्फा एंड बीटा बोथ. बाय एक्टिंग ऑन अल्फा 1 ये क्या करेंगे, बीपी को बढ़ा सकते हैं. बीटा एक्टिवेशन कैन इंक्रीज द हार्ट रेट, अल्टीमेटली दे कैन ऑल्सो इंक्रीज द ब्लड प्रेशर. In a patient with pheochromocytoma, which is an adrenal medulla tumor, we always say the drug of choice is going to be phenoxybenzamine. So the question comes, Can you only use phenoxybenzamine and treat this patient? The answer is no, you cannot, you will not. Reason being that phenoxybenzamine is a non-selective alpha blocker. They are irreversible, non-selective, longest acting non-selective alpha blocker. Yes, but मान के चलिए कि आपने इस अल्फा को ब्लॉक कर दिया. You have actually blocked the alpha. Have you cured the disease? No, the disease is still there. Have you cured the tumor? No, the tumor is still there. Then in that case scenario, catecholamine will continue, and now they are going to drive themselves. Their action will now be more diverted towards the beta. So do you think the BP will be controlled, the heart rate will be controlled? No, they will drive your heart crazy more, because all the catecholamine will now be available for all the beta receptor. More tachycardia, more palpitation, and BP again will not be under control. So examiner asks, okay, ठीक है, which drug should be added mandatorily? अगर आपको इतना पता है तो बता दीजिए. I think आसान सा है. Which drug is added mandatorily along with phenoxybenzamine in a patient with the pheochromocytoma? The drug that is added mandatorily with this is always going to be, guys, beta blocker. Beta blocker will mandatorily be added with this one. And what should be the order of the therapy? Hello, what will be the order? Please tell me, jaldi say, what will be the order of therapy? All of you, please. Order of therapy. Option will be like this. Give in any order. Give beta blocker, then alpha blocker. Give alpha blocker, then beta blocker. You never block beta first. मान लीजिए इसी कंडीशन में, if you are ever going to block the beta, है ना, let's assume that you first block the beta, or you said that take in any order and the person blocks the beta, और उसको पता ही नहीं है कि after that he must have to consume a drug. Let's say he forgets to take any drug and he first took out beta blocker and he blocked the beta receptors. If the beta receptors are blocked, now there is a problem. The BP was already very high. This epinephrine that we have now, they will be diverted more for the alpha, and you already know that this BP because of alpha 1 will be very high, and they can even lead to multiple complications like ischemia. More and more vasoconstriction can lead to stroke like scenario. ठीक है, so BP further बहुत ज़्यादा बढ़ जाएगा. BP will be more and more increase. Therefore the order of the therapy should always and always be, you should never give beta blocker first. It should always be alpha blocker and then beta blocker. So order of the therapy is always going to be alpha blocker के साथ में देना, alpha blocker के बाद देना है beta blocker. This should be the order of the therapy. ठीक है. So remember, in a vasomotor reversal of Dale, if you give only alpha blocker, there will be reversal of the problem, है ना. तो BP can fall down, but again heart rate will be high, and if heart rate will be high prolonged long term में, again they will also lift the blood pressure. ठीक है. तो ये समझ में आ गया. तो वैसोमोटर रिवर्सल ऑफ डेल, टू इंपॉर्टेंट क्वेश्चन. हाउ टू एलिसिट अल्फा ब्लॉकर के प्रेजेंस में यू विल बी गिविंग हाई डोज ऑफ एपिनेफ्रिन. व्हाट टाइप ऑफ आंसर क्वेश्चन विल बी आस्क्ड? ऑप्शन मैं बता दे रहा हूँ, एग्जैक्ट ऑप्शन. Vasomotor reversal of Dale is elicited by option like this: alpha blocker then beta blocker then alpha blocker, epinephrine then norepinephrine, alpha blocker then high dose of epinephrine. सेम काइंड ऑफ ऑप्शन विल बी देयर एंड यू गाइस विल गेट कंफ्यूज. ये अल्फा के बाद बीटा था, बीटा के बाद अल्फा था, और वहीं रह जाएंगे, लेकिन ऑप्शन तो करेक्ट आंसर विल बी समवेयर डाउनस्टेयर्स, है ना. अल्फा ब्लॉकर फॉलोड बाय बीटा ब्लॉकर. सो फॉलो अप बीपी ऑन एड्रेनलिन इंजेक्शन ओनली? नो. फॉलो अप बीपी ऑन एड्रेनलिन इंजेक्शन इन प्रेजेंस ऑफ अल्फा ब्लॉकर? यस. ठीक है. In a hospital setting, the anesthetist uses a quaternary amine anticholinergic drug as a pre-anesthetic medication, which decreases the bronchial secretion and relaxes the bronchus, which is helpful in anesthesia. Now, anesthesiologist, any of your friends, those who are in anesthesia, or any of my friends, those who are in anesthesia, they love any drug that causes decrease in secretion. They love any drug that causes dryness. उनको dry surface बहुत पसंद है. वाई? बिकॉज इफ द सर्फेस विल बी ड्राई, इफ द pathway of airway will be dry, the anesthesia induction will be much better, है ना. And plus there will also be decrease in the risk of aspiration. So they always give pre-anesthetic drug. Now here examiner is telling that anesthetist uses a quaternary amine. So a quaternary amine that he utilizes glycopyrrolate. It is one of the quaternary amine. And what is the role and what is the meaning of quaternary amine? Any drug that has quaternary amine, they actually do not cross the blood-brain barrier. They do not cross the blood-brain barrier. This glycopyrrolate can be utilized as a pre-anesthetic drug because of its anti-secretory property, and this was also one of the question. Pre-anesthetic drug के फॉर्म यूज कर सकते हैं. It can also be used in COPD because they are anticholinergic drug, है ना, M3 antagonist है ये. Can also be used in a patient with a bronchial asthma. ठीक है. Tiotropium definitely can be used, but tiotropium is not a quaternary amine. Dicyclomine is an anticholinergic drug that is used for the spasmodic pain. ठीक है. नेक्स्ट, ड्रग रिमेनिंग इन द बॉडी आफ्टर 3 हाफ लाइफ्स. 3 हाफ लाइफ के बाद बॉडी में कितना ड्रग बचेगा? ड्रग रिमेनिंग इन द बॉडी आफ्टर 3 हाफ लाइफ, बताइएगा प्लीज. व्हाट्स योर आंसर? सो when you start from a basic, let's say you are starting from 100 and you know that after 1 half life, what is half life guys? What is half life? What is half life? Time which is required to bring the plasma concentration to half of the previous plasma concentration. Time which is required to bring the plasma concentration to half of the plasma concentration. So if there is 100, in how many hours it will become 50? That will be 1 half life. ठीक है. Then in the next one, in the second half life, this will become further half. So in the next half life, the first half life में you saw it is becoming half. Next half life में उसका भी half. Then you know already that there is going to be 12.5. There is also going to be 6.25. This cycle will keep on going. So in the third half life, in the fourth half life. ठीक है. Examiner is asking drug remaining in the body after 3 half lives. So simple सा क्वेश्चन है ना. फर्स्ट हाफ लाइफ बाद आधा बचा, उसके फर्स्ट हाफ लाइफ बाद 25% बचा, एंड आफ्टर 3 हाफ लाइफ द वन दैट इज रिमेनिंग इज 12.5. देन इफ द एग्जामिनर इज गोइंग टू आस्क यू हाउ मच ऑफ द ड्रग इज एक्सक्रीटेड आफ्टर 3 हाफ लाइफ, excreted after 3 half life. So you already know that will be 87.5, or in when this question was asked in the examination, remember 87.5 was not in the option. So closest option was like this 25, 50, 75, 90, 90 ऐसे करके option में था ना. तो the closest answer was 90, so 90 was the correct answer. Okay. So after 3 half life, the amount of drug that is remaining is going to be 12.5. T half life is time which is required to bring the plasma concentration to half. कितने समय में आता है? This T half life that we know guys, it is directly proportional to volume of distribution. That means higher the volume of distribution, higher will be the T half life. Higher the volume distribution, higher will be the T half life. ठीक है? And T half life that we have, it is inversely proportional to clearance. इसका मतलब if the clearance will be more, T half life will be lesser. If the clearance is less, T half life will be more. Therefore, we can say that the T half life is equal to we take a constant value of 0.693, which is a log value of 2 into volume of distribution and clearance. So here we have also summarized and simplified the formula for T half life as well. Formula for T half life also has been discussed here for all of you guys. All right. So 0.693 into volume distribution and clearance. So this will be the correct answer for A. Will be correct answer for this question. Now this one. True statement about the order of kinetics. Order of kinetics. In a first order, T half life is increases. Now remember, in the first order, whenever they say first order, fraction of elimination is always going to be constant. Fraction of elimination is always going to be constant. How much fraction? That is, if example you are going to take, let's say 35%, it can be let's say 45%, it can be let's say 50%, any number, whatever number that is there, this is going to be constant. Fixed fraction of the drug will be eliminated. Fixed fraction. Okay? Fixed fraction. You guys can give the answer to this question. You can give the answer to this question and then we can discuss accordingly. Let's say that there is one condition where there is a plasma concentration of 100. If it is following first order kinetics and I am starting, let's say 50 का एक number ले लेते हैं for the ease of calculation. So this 50% अगर निकलेगा तो in the first half life it will become 100 will become 50 because again fraction of elimination is constant. Then in the next half life this 50 will become again 25. Now every time there is elimination of 50%. So fixed fraction of drug is being cleared. Fixed fraction of drug is being cleared. If I increase the plasma concentration from 100 to 200, what will happen? If I increase the plasma concentration from 100 to 200, do you think any change will happen in the T half-life? No. Because it is 50%, immediately this 200 will become 100 in the very first half-life. मैंने plasma concentration को double कर दिया, 2 times कर दिया, then again in the very first half-life again it will become 50. So fixed fraction of the drug is being cleared. There is no change. If you are going to make the plasma concentration to 400, once again this 400 will become 200 in the very first half-life. But what is changing every time is the rate of elimination. If the plasma concentration was 100 and 50% is removed, that means 50 milligram is removed. But if the plasma concentration is doubled, now 50%, that means 100 will be removed. So higher the plasma concentration, higher amount of drug is eliminated. If the plasma concentration is 400, now 200 will be eliminated. Again, higher the plasma concentration, higher is the rate of elimination. Therefore, what we learn here that in the first order kinetics, three important parameters: rate of elimination, clearance, and T half-life. So rate of elimination in the first order kinetics, it is going to be directly proportional to plasma concentration. What does it mean? Higher the plasma concentration, higher the amount of drug is being eliminated. That is rate of elimination. Clearance, it is going to be constant. T half-life, it is also going to be constant. No matter what is the plasma concentration, T half-life is not changing. In the very first half-life, it is becoming half. If the plasma concentration, even if I am taking from 400 to 800, in the very first half-life, it will become half. Clearance is constant. Fixed fraction of drug is being cleared, है ना? उसमें कोई changes नहीं है. Fixed fraction of drug is being cleared. So fraction of clearance is always and always going to be constant. If I compare the same with the zero order में कैसे आएगा वो मैं next slide में देख लेता हूँ. In zero order, the fraction is not constant. The amount of drug that is eliminated is going to be constant. Zero order में क्या constant होता है? Amount of drug that is being eliminated is going to be constant. Now, because in the previous example I have taken 50 as an example, here also I will take, let's say, 50 milligram as an example. ठीक है, amount. तो मान लीजिए if you are going to start a drug from 100 plasma concentration, because it is 50 milligram, let's say 50 milligram एक रेट लिख देते हैं 50 milligram per hour. ठीक है, एक रेट लिख दिया 50 milligram per hour. तो 100 will become 50 in the very first hour. And because of this reason, if I ask you, because 100 is becoming 50 here, what will be the T half-life, guys? यहाँ पे T half-life क्या होगा? Only 1 hour. 1 घंटे में आता हो गया. So this is pretty much similar to what I have discussed in first order. What's the difference? We will see the difference. What I'm trying to show here that a zero order kinetics or first order kinetics is not having much difference in the lesser plasma concentration. कम plasma concentration पे दोनों almost similar behave करते हैं, but only at the high plasma concentration the problem will be seen. Let's see how. Because 50 will now become 0 because this is going to be same 50 milligram per hour. ठीक है, अब थोड़ा सा इसमें ट्विस्ट डालते हैं, कहानी में मसाला डालते हैं. If I increase the plasma concentration from 100 to 200, now what will happen? From 100 to 200, this will again 50 milligram per hour. So this one will become 150 and 150 will become 100. So again 50 milligram per hour, it is not going to change. Rate of elimination is not going to change. Any plasma concentration, rate of elimination is independent of plasma concentration. वो change ही नहीं होगा. Here also it is going to be 50 milligram per hour. Now what you see that क्लियरेंस तो मतलब क्लियरेंस नहीं, रेट ऑफ एलिमिनेशन तो सेम है. बट व्हाट इज हैपनिंग टू द टी हाफ लाइफ? नाउ कैन यू टेल मी, this 200 is becoming 100. T half life मतलब time which is required to bring the plasma concentration to half. So when I increase the plasma concentration to 200, what is the T half life? Is it changed or is it the same? Hello, is it same or is it changed? कुछ अंतर है क्या? जल्दी से बता दो. Yes, the T half life यहाँ 1 घंटे था. Now the T half life will change to 2 hours. This doesn't end here. If I further increase the plasma concentration from 200 to let's say 400, then this 400 will become 350. 400 will become 350. This 350 will become 300. ये चलता जाएगा. 300 will become 250. And this 250 will now become 200. So if I ask you guys that 400 is becoming 200 in how many hours? 400 is becoming 200 in how many hours? तो यहाँ से आने तक की जो टी हाफ लाइफ की जो जर्नी है, now it will change to 4 hours. Higher the plasma concentration, higher is the T half life. इससे बेहतर क्या चाहिए आपको? एकदम क्रिस्टल क्लियर कॉन्सेप्ट रखिए. What all things are changing, what all things are unchanged. So let us talk about again the 3 parameter: rate of elimination, clearance and the T half life. Guys, since the amount is constant, rate of elimination, no matter what happened, it is unchanged. 50 milligram, even if you make the plasma concentration to 800, it will be 750, 700, 650, ऐसे करके आएगा. So rate of elimination is always and always going to be constant. Clearance and T half life, this is two challenge. T half life I told you, जैसे जैसे plasma concentration is increasing, वैसे वैसे T half life is increasing. That means T half life is directly proportional to plasma concentration. Higher the plasma concentration, higher is the T half life. I hope it is making sense. Yes. Now what happens to the clearance? You see, clearance every time is changing. If the plasma concentration is 100, amount of drug that is eliminated is 50 milligram. तो 100 में से 50 निकल गया, that means it is going to be 1/2 clearance, half clearance, 50%. 1/2. But if I am going to take from 200 to 150 clearance, अब क्या हुआ? 200 में से 50 निकल गया, so that will be almost 1/3. So high plasma concentration पे clearance C is becoming much lesser. If I am taking the plasma concentration, let us say 400 and 400 अगर 350 बनता है, that means 50 milligram removed. So now the amount of drug that is being cleared out is going to be 1/7. So every time you increase the plasma concentration, the fraction of the clearance is reducing by its size. Are you guys following me here? Hello, are you guys following me here? Yes. So let's repeat again, and you can also do this with the help of formula also. Formula में भी आपको मिल जाएगा. क्लियरेंस का फॉर्मूला लगाओगे तो ऐसे ही आएगा. हायर प्लाज्मा कंसंट्रेशन पे lesser amount of drug is being cleared, है ना? So clearance, as I told you, that when the plasma concentration is 100, when the plasma concentration is 150, that means here is going to be 1/2 clearance. Here it is, if it is 200, then here we have, let's say, 1/3 का clearance, and here it is going to be 1/7. So high plasma concentration clearance is decreasing, so we say clearance is inversely proportional to plasma concentration. Are you guys following me? Hello, are you all there? है ना? चलिए अब आते हैं बात. True statement about the order of kinetics. In the first half life, T half increases. Does it increase? First half life, no matter what is the plasma concentration, T half life is not increasing. No matter जो भी हो जाए, T half life नहीं increase होगा. Zero half life, T half life is zero order में T half life constant. No, in the zero, higher the plasma concentration, higher is the T half life. Again are wrong. ठीक है? In a first order, clearance is constant. In a first order, clearance is constant. When I say clearance is constant in the first order, did you saw clearance is actually constant in the first order? But in the zero order, clearance is more at high concentration. No, clearance is less at high concentration. I told you that is why zero order kinetics is dangerous. because at the high plasma concentration the drug will keep on getting accumulated inside the body, and in the zero order kinetic the clearance will be lesser at the high concentration. So all the drugs will follow first order kinetics, only few drugs follow zero order kinetics. So there is going to be only a handful of drug example of drugs that are following zero order kinetics. Example of a drug that is following zero order kinetics. So it is going to be unfractionated heparin, phenytoin, unfractionated heparin, phenytoin, aspirin, ethanol, tolbutamide, theophylline, and warfarin. I used to tell you a story here, a very small story, which help you in remembering and recalling the drugs that are following zero order kinetics. That if it is zero, it's like a zero that you are getting in any race. So getting zero in a race, in a competition, is like a war. You can't get zero, and getting zero in a competition, in a race, is like a war. This is just a story, okay? Getting zero is like a war, and I will ask you that you put an end to this war. मेरे साथ एक बार बोलिएगा, हमेशा के लिए याद हो जाएगा. You put an end to this war. Who will put an end to this war? Hello, who will put an end to this war? It is your war. You will put an end to this war. You put an end to this war. बोलिए एक बार मेरे साथ. You put an end to this war. आंखें बंद करके बोलिए. You put an end to this war. You unfractionated heparin, phenytoin, aspirin, ethanol, tolbutamide, theophylline, warfarin. Getting zero in an examination is like a war. Who will put an end to this war? You will put an end to this war. Okay. All right. So these are the example of drugs that are following zero order kinetics. Let's see the next one. Next one is going to be about schedule which regulate the sale of antimicrobials. Schedule which regulate the sale of antimicrobials in order to control over increasing rate of resistance. To check over unauthorized sale of antibiotics, we have a schedule by the name of H1 schedule, and all the drugs that we have under H1 schedule, they are mainly going to be identified. If you have seen any antibiotic, or if you are recently seeing someone eating any antibiotic, you see, look at the antibiotic. On the left hand side of this antibiotic, on the left hand side, there is going to be a red line here. आपको left hand side पे यहाँ पे एक आपको red line मिल जाएगा. तो अगर आप में से कोई अभी यूज़ कर रहा है तो आप खुद भी देख सकते हैं, एक red line आपको दिखेगा यहाँ पे. So whenever there is a red line on the left hand side on this antibiotic, this means this drug is coming under schedule H1 to check over unauthorized sale of antibiotic. To check over the unauthorized sale of antibiotics, we are going to utilize schedule H1. Okay. So other schedules that we have, H that we have, that this drug should be sold only on a prescription of a RMP. H का मतलब क्या हुआ? H मतलब जो हम देंगे, हम क्या, हम सब RMP हैं. So this drug to be sold, सेल की बात कर रहे हैं, only on a prescription of RMP. What is RMP? Registered medical practitioner. Who is RMP? बोलिए, हम हैं RMP, जो हम देंगे, और ये दवा तभी देना है जब हम देंगे. हम कौन है? हम सब हैं RMP. This drug should be sold only on a prescription of RMP. That will be H. G is going to give you the guidelines or the caution that says not to be given except under medical supervision. ये intake की बात कर रहे हैं. Not to be given except under medical supervision. Except under medical supervision. ठीक है, except under medical supervision. Now a couple of more schedule that you can just quickly take a look and revise. One will be schedule W, जो वर्ल्ड वाइड सेम नेम से मिलता है. दैट मीन्स शेड्यूल W इज गोइंग टू डील विद द जेनेरिक ड्रग्स. तो आई से दैट जेनेरिक ड्रग्स दे आर अवेलेबल सेम नेम वर्ल्ड वाइड. है ना. Then we have schedule X. X is like any other X that you hear in our actual life. X, the dangerous X. और वो X हैं तो इसलिए याद करिएगा कि X's are usually psycho X. So these are going to be psychotropic drug that require a specific license for manufacture and sale. So all the psychotropic drug they come under X, and psycho X है, they have a high abuse potential as well. Their abuse potential is also going to be very, very high. They have a high abuse potential. Example, drugs like, let's say, ketamine, LSD, barbiturate, which I'm writing as the barbs, opioids like morphine. So all these are actually classified under schedule X. X बहुत ही डेंजरस थी, है ना, या है. अच्छा, अगर है तो X तो होगा नहीं, माय बैड, है ना, वो तो प्रेजेंट होगा. लेकिन अगर X हो जाएगा तब उसको आप साइको, या X हो जाएगी तो आप उनको साइको बोल सकते हैं. तो जस्ट अ वे टू रिमेंबर, X साइको था या साइको थी. वर्ल्ड वाइड सेम नेम जेनेरिक ड्रग्स, है ना. G जो गाइडलाइन देता है ना. H1 आई टोल्ड यू टू चेक ओवर अनदर सेल ऑफ एंटीबायोटिक्स. सो मेनली it will be mainly for the antibiotics, not any other class of drug, only for the antibiotics. ठीक है. And we have one more schedule Y is for running a clinical trial. So schedule Y, it is mainly dealing with the clinical trial. ठीक है. So for running a clinical trial, all the guideline has been given in the schedule Y. ठीक है. Now S यहाँ पे दिया हुआ है, not important from the allopathic point of view, but if you want to know what is S actually, so remember S, ये कॉस्मेटिक प्रोडक्ट्स आते हैं इसमें. तो आपको याद करने में मैं बता रहा हूँ, जो सुंदरता बढ़ाने वाले ड्रग होते हैं वो एस में आते हैं. तो मेनली सुंदरता तो क्या ही बोलोगे आप लोग, कॉस्मेटिक प्रोडक्ट्स बोलिए, है ना. कॉस्मेटिक प्रोडक्ट्स आर कमिंग अंडर एस. ट्रू अबाउट फेज 2 क्लिनिकल ट्रायल आर ऑल एक्सेप्ट फर्स्ट ट्रायल टू बी डन ऑन पेशेंट. यस, बिकॉज फेज 1 एंड फेज 0 इट इज डन ऑन द नॉर्मल हेल्दी वॉलंटियर्स. They are mainly done on the normal healthy volunteers. So first time whenever you know enroll, you are going to enroll the patient for the very first time in the phase 2. There are some exception like let's say chemotherapeutic agent, antiretroviral drug, है ना. तो वो वाले में phase 1 से ही हम usually patient को enroll करते हैं. And to determine mainly the efficacy and safety, yes, open label नहीं होता है. You have to find out an all accept. It's not open. Open label means everyone is aware who is taking what kind of drug and what is the possible ADR. So it is not an open label study. Open label study नहीं होते हैं, right? Open label मतलब everyone is aware who is taking what kind of drug and what is the possible ADR. So phase 2 clinical trial का study design अगर आप पढ़ते हैं, so in the early part of phase 2 clinical trial there will be blinding. उसको बोलते हैं single blinding. A single blinding will be done. So only the let's say the participant is not aware whether he is taking active compound or placebo. And in the late part of phase 2 we are going to do double blinding. Double blinding का मतलब क्या हुआ कि neither the researcher nor the participant, दोनों में से नहीं पता है कि कौन एक्टिव कंपाउंड ले रहा है, कौन प्लेसिबो ले रहा है. तो दिस विल बी अगेन इंक्रीजिंग द रिलायबिलिटी ऑफ द स्टडी के बायस को कम करने के लिए हम ब्लाइंडिंग करते हैं यूजुअली. ठीक है. तो फेज 2 इज नॉट ओपन लेवल. ओपन लेवल कौन कौन से होते हैं? ओपन लेवल इज ऑलवेज गोइंग टू बी 1 and 4 विल बी ओपन लेवल. फेज 3 इज ऑल्सो हैविंग ब्लाइंडिंग. फेज 3 में भी डबल ब्लाइंडिंग करते हैं. पहले डबल ब्लाइंडिंग, बाद में उसको क्रॉस ओवर भी करते हैं. Maximum risk of failure also happen in phase 2 because you are actually exposing your drug to the patient for the first time. ठीक है. So study design अगर मैं बात करूं तो 1 and 4 open level हो गया. Phase 3 that we have, they are also going to be double blinding study. Double blinding, it's a type of randomization, randomized control trial, RCT study होते हैं ये. Double blinding, after half of the study you are going to do crossover. So crossover का मतलब Till half of the study you are going to give one drug, and after half of the study you are going to give other drug, and after till half of the study, let's say we are having two drugs and we are having two compounds. तो one drug will be given to one person, one drug will be given to the other group, है ना. दो ग्रुप है, दोनों ग्रुप को दे दिया. After half of the study, what I'm going to do, I'm going to switch this drug. Now this drug that I'm going to switch here, do remember, they look same, their color is same, weight, पैकेजिंग एवरीथिंग इज सेम, बट बोथ आर हैविंग जस्ट कोडेड, दोनों को कोड किया गया. लेट्स से नंबर विल बी गिवन लाइक 1 and 2. सो नाइदर यू नो नॉर मी, यू एज अ पार्टिसिपेंट, मी एज अ रिसर्चर, वी बोथ आर नॉट अवेयर विच बॉक्स और विच पर्टिकुलर पैक इज हैविंग एक्टिव कंपाउंड और विच वन इज हैविंग प्लेसिबो. ठीक है. When two chemical act on two different receptor producing opposite response to each other, this is called two agents acting at a two different sites. So let us say we are having two agents. So we have one drug here and we are having one more drug here, and it is saying that both these agents are working at a different site and producing opposite action. They are producing opposite action. So एक drug number 1 हो गया, and this is going to be drug number 2, and they will be working on their specific receptors. So drug number 1 is, let's say, going to work on receptor number 1, and drug number 2, let's say, is going to work on receptor number 2. ठीक है. Now if you are going to see these two receptor का structure and shape, and I ask you that what are the chances that drug number 1, this is known as D1, that is drug number 1, this is known as drug number 2, receptor number 1 and receptor number 2, what are the chances drug number 1 will ever make a bond with receptor number 2, or vice versa, what are the chances drug number 2 will ever make a bond with receptor number 1? क्या chance है that drug number 2 will ever compete with drug number 1 for the same site of receptor number 1? There is no chance. But when drug number 1 binds at its own site and drug number 2 binds its own site, and they produce action opposite to each other, we call this one as a physiological antagonist. We are going to call them as a physiological antagonist. Very, very frequently asked question. A very good example that I can give all of you guys is going to be, let's say drug 1 is going to be adrenaline, and the name of the receptor is beta receptor, and drug 2 is going to be histamine, and the name of the receptor histamine is going to be H1 receptor. So you already know when they work on the let's say lungs पे काम करेगा, तो adrenaline if it is going to work on the lungs, they will be causing bronchodilation. Histamine if it is going to work on the H1, they will be causing bronchoconstricting effect. दोनों अलग अलग काम कर रहे हैं अपने अपने अलग अलग रिसेप्टर पे, बट द आउटकम इज गोइंग टू बी अपोजिट. सो वी कॉल दिस वन एज अ फिजियोलॉजिकल एंटागोनिस्ट. One more example I can give you, that another example number 2, that is also mentioned in the textbook also, glucagon and insulin. So glucagon is causing hyperglycemia and insulin is causing hypoglycemia. They never interfere in their each other's activity. They never interfere in the activity of each other. ठीक है. Adrenaline and acetylcholine on the heart rate. Adrenaline will act on the beta receptor. Adrenaline is going to act at the beta 1 receptor and they are going to cause increase in the heart rate. Acetylcholine will be acting on M2 receptor and they are going to cause decrease in the heart rate. So adrenaline and acetylcholine can also be an example of physiological antagonist. Two agents acting at a two different site, two agent that is acting at two different site as an agonist and producing opposite activity, उसको हम बोलते हैं physiological antagonist. However, what are the other antagonists? Like chemical antagonists. So let me write on the next slide here. Chemical antagonist क्या होते हैं? Hashtag sign I am using for antagonist. Chemical antagonist. All the chelators are going to be example of the chemical antagonist. Chelators. Like for example, let's say digibind is a chemical antagonist for digoxin. Digibind is a chemical antagonist for digoxin. Dipenicillamine is a chemical antagonist for copper. So all the chelator are going to be chemical antagonists. Then we are also having one more called pharmacological antagonists. So pharma guys are very, very competitive. Pharma guys are always very competitive. So we are having pharmacological antagonists, which is also given the name as a competitive antagonist, which is always given the name as a competitive antagonist. They are going to compete for the same site. So what happens in this one, in the pharmacological antagonist, there are going to be two agents that will compete for the same site. So let's say this is drug number 1 and we are having one more that is known as drug number 2. Okay, so we have two drugs here, drug number 1 and we are having drug number 2. Okay, we have two drugs and both these two drugs, they are going to compete for the same site. If they compete for the same site and after binding at the same site produce opposite action, उसको हम बोलते हैं pharmacological antagonist. Two agents competing for the same site and producing opposite action, we are going to call it as a pharmacological antagonist. So let's understand by the example. Drug 1, let's say drug 1 is adrenaline ले रहे थे तो adrenaline ले लीजिए. Drug 1 is let's say adrenaline and this is let's say is a propranolol, that is a beta blocker. And if this is a beta receptor, you already know that when drug 1 will bind, they will increase the heart rate. When drug 2 will bind, they will block and they will decrease the heart rate. So two agents competing for the same site but producing opposite action. So adrenaline and propranolol can be a pharmacological antagonist of each other. Adrenaline and propranolol can be pharmacological antagonists. Chelators are all the chemical antagonists. And other example can be, let's say, acetylcholine and atropine, because when acetylcholine act, they will cause bradycardia, and at the same side atropine will also be working, that is going to cause the tachycardia. So adrenaline and adrenaline and propranolol are the pharmacological antagonists. They are competing for the same side. Acetylcholine is a M2 agonist and atropine is a M2 blocker. So they are both going to compete with the same side, but they have opposite action. Two agents competing for the same site producing opposite outcome is pharmacological antagonist. ठीक है. So एक और है आपका pharmacokinetic antagonist. Pharmacokinetic antagonists, remember guys, they are mainly the enzyme inducers. Enzyme inducer that is going to increase the metabolism, and once they increase the metabolism, the overall concentration of the drug will be reduced. They are going to decrease the concentration of the compound. Overall, enzyme inducer will increase the metabolism and they can also lead to even treatment failure. Okay? So they are pharmacokinetic. You are simply increasing one of the pharmacokinetic property like metabolism. Okay. Therapeutic index is an indicator of. So therapeutic index, guys, therapeutic index, what we know is going to be a ratio of a dose that is causing lethality in 50% and effect in 50%. उसको बोलते हैं therapeutic index. And उसको याद करने का simple mnemonic भी हमने बताया है आपको कि you can remember by the simple mnemonic of TILE. Therapeutic index is equal to lethal dose divided by the effective dose. And at any point of time, when the therapeutic index is very, very narrow, such drugs are given as unsafe drug name. They are unsafe. Ideally, we should not give, but if you do not have any other option, remember, therapeutic drug monitoring will be required in that case scenario. TDM is going to be required in that case scenario. And if it is going to be a wide therapeutic index, thus those drugs are going to be relatively safer drug. A dose that is causing lethality in 50% divided by a dose that is causing therapeutic effect in 50%, उसको हमने बोला TILE निमोनिक से आती है, that is therapeutic index. उसको हमने बोला क्या? Therapeutic index. All right. Let's understand here. Let's say that we have a x and y axis graph. Okay. And in this x and y axis graph, whenever we give any dose initially, we get some therapeutic benefit, right? So let's say you are going to give a drug, और एक drug दिया आपने, and this is the maximal amount of responder. This is the log का dose, and this is going to be on the y axis. This is going to be your percentage of responder. रेस्पॉन्डर्स, ध्यान रखिएगा वाई एक्सिस में लिखा रेस्पॉन्डर्स. सो अ डोज दैट इज इनिशियली गिवन इट विल बी कॉजिंग थेराप्यूटिक इफेक्ट, राइट, थेराप्यूटिक इफेक्ट. इफ यू इंक्रीज द डोज टू मल्टीपल टाइम्स, मान लीजिए आपने इसके डोज को कई गुना बढ़ा दिया, लेट्स से यू आर गोइंग टू इंक्रीज टू 10 टाइम्स, 15 टाइम्स, 20 टाइम्स, same drug that was causing therapeutic effect will now be causing some lethality as well. Same drug that was causing therapeutic effect can now cause lethality as well. So this will be producing some lethal effect. पहले therapeutic effect था, अब क्या होगा, lethal effect होगा. ठीक है. Now a dose that can create therapeutic effect in 50%, a dose that can create therapeutic effect in 50%, उसको मान लीजिए ये 100% रेस्पॉन्डर हो गया, दिस विल बी 50% रेस्पॉन्डर, उसको हमने नाम क्या दिया, ED50, because initially there will be therapeutic effect. So what is the dose? This is the dose that we have. A dose that can create therapeutic effect in a 50% responder is known as ED50. क्या नाम होगा इसका, ED50. Effective dose in a 50%, not 49, not 51, ED50. एक ऐसा डोज जिससे 50% of the experimental population are showing therapeutic effect. However, if they increase the dose to multiple time, a dose that can actually kill or a dose that can create sidal effect in a 50% of the responder, 50% of the experimental population, उसको हम बोलते हैं LD50. उसको क्या बोला हमने, LD50. So this is given the name as the LD50 lethality. Now इन दोनों के बीच में जितना ज्यादा गैप होगा, the more the gap, the bigger the gap, the more safer the drug we consider. If I say that this is the therapeutic effect and the very next dose is going to produce lethal effect, will you say that this is a very safe kind of drug? You can see one dose is causing therapeutic effect, other dose is causing lethality. So this is very narrow safety margin. So this particular difference that we have, a dose that is producing therapeutic effect in 50% of responder and a dose that is producing lethality in 50%, इस पर्टिकुलर की समरी को, इन दोनों के बीच के जो डिफरेंस है, द रेशियो है, दिस रेशियो इटसेल्फ इज गिवन द नेम एज, है ना, इस रेशियो को ही हमने क्या नाम दिया है, दिस रेशियो इटसेल्फ इज गिवन द नेम एज, है ना, थेराप्यूटिक इंडेक्स. इसी को हमने नाम दिया थेराप्यूटिक इंडेक्स. ठीक है, दिस इज द वन. दिस वन इज नोन एज योर therapeutic index, a dose that can create therapeutic effect in 50% and a dose that can create lethality in 50%. If it is going to be very, very narrow, we are going to say they are going to be very, very unsafe drug. However, one more term that you hear more many times, इसको बोलते हैं therapeutic window. Let's understand what is that therapeutic window, क्योंकि वो भी क्वेश्चन बार बार आपके एग्जाम में आता रहता है. So therapeutic window is you are going to consider on the same drug कि कब से अफेक्ट आना शुरू हुआ और कब अफेक्ट जाके बंद हो गया. सो लेट अस से सिमिलर काइंड ऑफ ग्राफ आई हैव ड्रॉन हियर, जो भी मैंने आपको पहले ड्रॉ किया था. ठीक है, नाउ इट्स विजिबल. सो इन दिस वन, इन दिस ग्राफ व्हाट वी आर गोइंग टू सी हियर, that whenever you are going to start a drug, आपको इनिशियली इफेक्ट नहीं आ रहा है. अफेक्ट कहाँ से आना शुरू हो रहा है, यहाँ से अफेक्ट आना शुरू हुआ. ठीक है, यू आर गेटिंग द इफेक्ट फ्रॉम समवेयर हियर. और जो मिड लाइन का स्ट्रेट पोर्शन है, दिस इज द क्लिनिकली सिग्निफिकेंट वन. और एक समय के बाद इट द इफेक्ट हैज स्टॉप्ड. आफ्टर सम टाइम देयर इज अ प्लेटू फॉर्मेशन, है ना, प्लेटू इफेक्ट आना शुरू हो गया, राइट. सो a time at which the effect has started to come, यहाँ से लेकर के a time at which the effect has plateaued, इन दोनों के बीच का जो जर्नी है, इन दोनों के बीच का जो डिफरेंस है, दिस इज गिवन द नेम एज द थेराप्यूटिक विंडो. ठीक है, इसके बीच को हमने क्या नाम दिया, दिस इज गिवन द नेम एज अ थेराप्यूटिक विंडो. कब से इफेक्ट आना शुरू हुआ और कब तक आके प्लेटू हो गया, इसको हमने क्या नाम दिया, थेराप्यूटिक विंडो. सो आई होप इट इज प्रेटी क्लियर टू ऑल ऑफ यू गाइज कि थेराप्यूटिक विंडो उसी ड्रग में कब से स्टार्ट हुआ, कब जाकर प्लेटू हो गया. एंड थेराप्यूटिक इंडेक्स, अ डोज, किस डोज पे थेराप्यूटिक इफेक्ट आया, कितने डोज पे जो है कि लिथालिटी आना शुरू हुआ, ठीक है। सो दैट इज थेरापेटिक विंडो एंड थेरापेटिक इफेक्ट, बोथ ऑफ देम आर सॉर्टेड हियर, ठीक है। जस्ट अ मिनट। ऑल राइट, आई थिंक इस सवाल का जवाब हो गया आप सबके लिए। Let's quickly see. The therapeutic index is an indicator of, it's a measure of safety. Therapeutic index is a measure of safety, actually. It's a measure of safety. Therapeutic index is a measure of safety. Let's see the next question, guys. A patient is on valproate for his epilepsy, acquired tuberculosis, and he started on first-line anti-tubercular drug. After a few days, there were complaints of recurrence of epileptic episode. What kind of drug interaction is most likely seen here? What kind of drug interaction have we seen most likely in this scenario? क्या drug interaction मिलेगा? What kind of drug interaction do we see here most likely? So in a patient who is on valproate, we already know that if there is anti-tubercular drug that is started, under anti-tubercular drug we are having isoniazid, rifampicin, pyrazinamide and ethambutol. And you already know that rifampicin is a very, very potent enzyme inducer. And what we know about potent enzyme inducer, that inducers are always increasing the treatment failure risk because they can increase the metabolism, they will cause fast metabolism. Inducer will increase the metabolism, they will be causing fast metabolism. And what about inhibitor, guys? Inhibitor that we know, that inhibitors, enzyme inhibitor that we know, they are going to slow down the metabolism. They are going to inhibit the metabolism, slow down the metabolism, and because of this, the drug will continue to stay in the body and the person will keep on taking the next dose, and that can actually lead to slow metabolism की वजह से they can actually lead to increase in the risk of toxicity. There will be increase in the risk of toxicity. ठीक है. So again, what kind of drug interaction is seen? So we already know if anti-tubercular drug is started, decreased effectivity of the valproate due to ATT caused the effect, because I told you enzyme inducer will increase the metabolism and inhibitor will slow down the metabolism. Right? So we always say whenever you are in a relationship and you get induced every time, and you're also one of the NEET PG aspirant, don't get induced very rapidly. You get induced, you're getting a message, and you're attending a Pharma TND and you're getting a message, baby, where are you? Come home, I'm waiting for you. And that's it. You got induced, you went to home, and examination is just around the corner. Imagine the result. Result कुछ भी हो सकता है ना? Again, so what I'm trying to say here, inducer can increase the risk of failure, and if you keep on getting inhibited, आपको बार बार inhibition मिल रहा है, जितनी बार आप ट्राई कर रहे हो, जितनी बार आप कोशिश कर रहे हो, आपको बार बार inhibit कर दिया जा रहा है, आपको stop कर दिया जा रहा है. So when you keep on getting inhibited, बार बार आपके अंदर की toxicity जमा होगी, और toxicity definitely can burst any point of time. So remember, too much induction can cause failure, and inhibition again will be leading to toxicity, है ना? तो ध्यान रखिएगा, बहुत ज़्यादा induce भी नहीं होना है, inhibit भी नहीं होना है. What are the enzyme inducer that we already know? Griseofulvin, phenytoin, rifampicin, है ना? They are all enzyme inducer. Enzyme inhibitor that we have are remembered by the very, very simple mnemonic that I always say. एंजाइम इनहिबिटर का एक निमोनिक होता है पीकॉक वाला. आई ऑलवेज यूज्ड टू टेल यू दैट पीकॉक वाला आएगा, इनहिबिट करके जाएगा. पीकॉक वाला, दे आर गोइंग टू बी द एंजाइम इनहिबिटर. दैट इज प्रोटीज इनहिबिटर. ऑल द प्रोटीज इनहिबिटर आर एंडिंग विद द नावीर. देन वी आर ऑल्सो हैविंग ड्रग्स लाइक योर एरिथ्रोमाइसिन, क्लेरिथ्रोमाइसिन. दे आर फ्रॉम द सेम फैमिली. एरिथ्रोमाइसिन, क्लेरिथ्रोमाइसिन, एमायोडारोन, सिमेटिडीन, एमायोडारोन, सिमेटिडीन, ओमेप्राजोल, सिप्रोफ्लॉक्सासिन, कीटोकोनाजोल, कीटोकोनाजोल, और इसी का भाई होता है इट्राकोनाजोल, एंड वाला विल बी valproate. So only one anti-epileptic drug that we have in the list is valproate. All other anti-epileptic drugs like carbamazepine, barbiturate, phenytoin, they are all enzyme inducers. इंड्यूसर विल कॉज फेलियर. मैंने अभी स्टोरी बताया ना, अगर बहुत ज़्यादा इंड्यूस हो जाओगे तो फेल का डर है, और बहुत ज़्यादा इनिबिट हो जाओगे तो भी प्रॉब्लम है. इनिबिशन की वजह से देयर विल बी रिस्क ऑफ टॉक्सिटी. सो व्हाट इज द स्टोरी? पीकॉक वाला आएगा, इनहिबिट करके जाएगा। फिर से बोलिए, जहां कहीं भी हो जोर से बोलिए, पीकॉक वाला आएगा, इनहिबिट करके जाएगा, है ना। वाला विल बी वालप्रेट, वेरी वेरी इंपॉर्टेंट, दे आर द पोटेंट एंजाइम इनहिबिटर, एंड एंजाइम इनहिबिटर will always increase the risk of toxicity. True about the G protein coupled receptor. True about the G protein coupled receptor. G protein coupled receptor, इसके कई सारे नाम होते हैं, that is 7-pass receptor, heptahelical receptor because they are 7 times traversing the lipid bilayer membrane. 7-pass receptor, heptahelical because they are occurring this traversing because they are traversing around zigzag snake के फॉर्म में, तो उसको बोला गया सर्पेंटाइन रिसेप्टर, मल्टीपल नेम्स हैं। इट इज द फास्टेस्ट एक्टिंग रिसेप्टर। रिमेंबर द फास्टेस्ट एक्टिंग रिसेप्टर इज नोन एज द आयन चैनल वाले रिसेप्टर। आयन चैनल रिसेप्टर, लाइगेंड गेटेड रिसेप्टर द फास्टेस्ट एक्टिंग, है ना। आयन चैनल रिसेप्टर दे आर द फास्टेस्ट एक्टिंग रिसेप्टर। बीटा कंपोनेंट इज द एक्टिव वन, अल्फा इज द एक्टिव वन। G protein coupled receptor के यूजुअली देर आर 3 इंपॉर्टेंट कंपोनेंट्स इनसाइड। इंट्रासेलुलरली मान लीजिए दिस इज द लिपिड बाइलेयर मेम्ब्रेन, एंड इंट्रासेलुलरली दिस इज द 1 2 3 4 7। Extracellularly there will be ligand binding site, and intracellularly if we see here there are 3 important components that are available, and the name of these components are going to be alpha, the name of these components are going to be beta, and then there are also going to be gamma. So there are 3 components, alpha, beta and gamma, और इन सभी में alpha is the active one. Whenever there is any ligand that is going to be bind here, अगर कोई ligand यहाँ bind करता है तो suddenly a signal will be generated, suddenly एक signal आएगा, and this signal will be causing this dissociation between alpha and beta plus gamma का dissociation होगा। As soon as there will be a ligand binding outside, a signal will be generated immediately, and this signal what it is going to do, it is going to mainly cause over this resting phase where there is a GTP, mainly immediately this GTP will be replaced by GTP. GTP being the source of energy, when you see when the GTP occupies the site of alpha, when the GTP occupies the site of alpha, there will be a dissociation between beta plus gamma. Now it is the alpha that is going to do the activity. Alpha अपना काम करेगा, कैसे काम करेगा वो हम देखते हैं नेक्स्ट स्लाइड पे। How alpha is going to work, that is what we are going to see on the next slide. Because this alpha is the active one, what we know that alpha के further 3 important types होते हैं। अल्फा के फर्दर 3 इंपॉर्टेंट टाइप होते हैं। फॉर एग्जाम्पल, if I write G alpha, that means I'm talking about the active component of the G protein coupled receptor, G alpha. This is divided into G alpha S, G alpha I and G alpha Q. I'm not writing alpha again and again because as soon as I write GI, GS, GI, GQ, I'm actually considering कि अल्फा इज द एक्टिव वन, तो हम अल्फा के बारे में ही बात कर रहे हैं, राइट। हम अल्फा के बारे में ही बात कर रहे हैं। जी अल्फा, GS, GI and GQ. GS that we have, they are going to stimulate. S का मतलब ही है stimulation. S का मतलब क्या है? Stimulation. They are actually going to stimulate an enzyme called, they are going to stimulate an enzyme called adenylate cyclase. तो ध्यान रखिएगा, the enzyme that is getting activated here is known as adenylate cyclase. A typical question that was asked in 2022 NEET PG, that which of the following is acting by activating एडिनाइलेट साइक्लेस। तो एडिनाइलेट साइक्लेस के एक्टिवेशन से काम करेंगे वो सारे के सारे जीएस वाले होंगे। एंड व्हाट इज दिस एडिनाइलेट साइक्लेस एक्टिवेशन डूइंग? दिस इज गोइंग टू कॉज ब्रेकडाउन ऑफ एटीपी टू cyclic AMP. This is going to cause breakdown from ATP to cyclic AMP, ATP to cyclic AMP. All right. Now, cyclic AMP being a secondary messenger, they will be causing phosphorylation of calcium channel, increasing the permeability of calcium channel. More and more calcium will come inside, and they will be causing contraction. They are going to cause the contraction. Example of a receptor which is mainly working by GS, उनको हम याद करते हैं सिंपल निमोनिक से, इसको बोलता हूं मैं BDSH, और मैं बोलता हूं बादशाह, बादशाह, है ना। बादशाह स्टैंड फॉर ऑल द बीटा रिसेप्टर, बीटा 1, बीटा 2, बीटा 3, all the beta receptor. D for dopamine 1 receptor, S for 5-HT serotonin. सेरोटोनिन का कौन सा? सेरोटोनिन का 4 एंड हिस्टामिन का 2. सो BDSH बादशाह, जिसके पास सब कुछ है, बीटा है, डोपामीन है, सेरोटोनिन है, हिस्टामिन है, मेरे पास सब कुछ है, तुम्हारे पास क्या है? मेरे पास क्या है? कुछ नहीं है, है ना। सो बादशाह है तो बादशाह के पास सब कुछ है। BDSH, बीटा, डोपामिन, सेरोटोनिन, हिस्टामिन, एवरीवन इज हियर, ठीक है। नाउ दे आर एक्टिंग बाई स्टिमुलेटिंग एड्रेनालिक साइक्लेस। जीआई का काम इसी से सीधे उल्टा होगा, दे आर एक्चुअली गोइंग टू इनहिबिट द एंजाइम एडिनाइलेट साइक्लेस, AC is adenylate cyclase, and when AC is inhibited, what is going to happen, they are going to cause a less breakdown of ATP into cyclic AMP, so cyclic AMP level will be reduced। प्लस इसमें एक और ट्विस्ट ये है कि इसका जो बीटा एंड गामा कंपोनेंट है, दे एक्चुअली ओपन द एसिटाइलकोलिन सेंसिटिव पोटेशियम चैनल, they actually open the acetylcholine sensitive potassium channel, and I think you can easily understand if the potassium channel will be opened, they are going to cause more and more efflux of the potassium, and they can also lead to hyperpolarization of the membrane, they will also be causing hyperpolarization of the membrane। जिस बादशाह की मैं बात कर रहा हूं BDSH, उस बादशाह का नाम है एडोम्स बादशाह, ADOMSH। जिस बादशाह के बारे में मैं बात कर रहा हूं, द नेम ऑफ दैट बादशाह इज एडोम्स बादशाह, ADOMSH। दैट इज गोइंग टू बी योर अल्फा 2, डोपामिन 2। तो मेजॉरिटी ऑफ द 2 इज फेवरेट फॉर GI, ओपियोइड, right, alpha 2, dopamine 2, opioid। now are these the only, see I'm just writing the very important one, है ना, जो सबसे अल्ट्रा इंपॉर्टेंट है उन्हीं का नाम मैं लिख रहा हूँ, है ना, बिकॉज इफ यू राइट द एंटायर थिंग आई विल सिंपली बी क्रिएटिंग अनदर टेक्स्ट बुक फॉर यू विच आई डोंट थिंक विल बी beneficial much, because बुक तो आपके पास है ना। तो अगेन द अल्ट्रा इंपॉर्टेंट वन, लाइक देयर आर सम रिसेप्टर दैट आर ऑल्सो देयर इन योर GS, जैसे कि some sex hormones like luteinizing and all, they're also there, but I'm not writing everything just to make sure, ऐसा नहीं कि कुछ छोड़ रहा हूँ या छूट रहा नहीं, less important things we are just skipping it। now we are having opioid receptor, then we are having M2 and M4 receptor, and we are having serotonin S का कौन सा होगा, इकलौता 1 वाला जो Q में नहीं जाएगा वो यहाँ आएगा, एंड हिस्टामिन का कौन सा, H3 एंड H4, बिकॉज हिस्टामिन 2 GS में था। सो एक बादशाह जिसका नाम था एडोम्स बादशाह। GQ दैट वी हैव, GQ, they are going to act by activating phospholipase C, and this will be increasing the secondary messenger, that is your IP3 and DAG. They will also do the same thing, they are also going to increase more and more calcium influx, so their activity is pretty much similar to GS was causing this more calcium due to adenylate cyclase, but here the enzyme is changed, secondary messenger is changed, enzyme is phospholipase C, secondary messenger is IP3DAG. I think it's pretty clear to all of you guys, right? Now what are the example of receptor that is acting through phospholipase C? The example of receptor that is acting through phospholipase C or IP3DAG pathway, एक ऐसा बादशाह उसका नाम था एडोम्स, और एडोम्स बादशाह का मैथ्स इज अ क्वेश्चनेबल, आई ऑलवेज क्वेश्चन इज मैथ्स, MAATHS, बादशाह एडोम्स की मैथ्स इज क्वेश्चनेबल। व्हाई हिज मैथ्स इज क्वेश्चनेबल, वाज ही टू वीक इन मैथ्स? नो, मैथ्स क्वेश्चनेबल मतलब ये सारे के सारे GQ वाले हैं, मैथ्स इज क्वेश्चनेबल, तो एंटायर स्टोरी हो गया, बादशाह एडोम्स का मैथ्स इज क्वेश्चनेबल, तो यू हैव नो डाउट एट ऑल, देयर इज लैगिंग। गौरव, अखंड, विनय, वीडियो लैग हो रहा है, anything that we can do for the students? वीडियो लैग हो रहा है कुछ, just a minute guys, they are looking into it, just a minute। हेलो, काफ़ी ज़्यादा वीडियो लैग हो रहा है, हमारी क्वालिटी टीम क्यों नहीं देख रही है? जो टीम वीडियो लाइव क्लास कराती है, व्हाई आर दे नॉट नोटिसिंग? वीडियो लैग हो रहा है, बच्चों का कंप्लेन आ रहा है, वीडियो लैग हो रहा है, वीडियो इज लैगिंग।
अभी चल रहा है क्या?
अभी तो लाइव है। हाय गाइस, इज इट स्टिल लैगिंग? कैन यू रिप्लाई अगेन? काफ़ी लैगिंग है, बच्चे बोल रहे हैं। मतलब इतना इंटरेस्टिंग क्लास हो रहा है और क्या हो रहा है? क्या दूँ? फ़ोन मेरा। वीडियो बीच में रुक जा रहा है। So I was telling to all of you guys, मैं just एक सैम्पल ले रहा हूँ so that we can check again if the video is lagging. तो G alpha that we have, it is further subdivided into GS, GI and GQ. SIQ किस ऑर्डर में जा रहा है? SIQ. S is going to simply stimulate the enzyme adenylate cyclase. I is simply going to inhibit the enzyme adenylate cyclase plus इसका बीटा गामा कंपोनेंट दे ओपन द एसिटाइलकोलिन सेंसिटिव पोटेशियम चैनल को ओपन कर देता है। एंड GQ इज गोइंग टू एक्ट बाय स्टिमुलेटिंग फॉस्फोलाइपेज C which increases the IP3 and DAG, which increases the IP3 and DAG, that will be increasing the intracellular calcium, that is going to increase the intracellular calcium. ठीक है? Did you guys understand so far? कुछ समझ में आया आप लोग को ये वाला जी प्रोटीन का पल रिसेप्टर? सॉरी आई थिंक इट स्टार्टेड लैगिंग नाउ या शुरू से ही लैग हो रहा है? मेरे पास तो कुछ है भी नहीं, हाउ टू नो? इज इट लैगिंग फ्रॉम बिगिनिंग या अभी लैग होना शुरू है? बिकॉज एक बच्चे ने कंप्लेन तो किया था शुरुआत में, इंटरनेट इशू है। मैं चालू करूं? ओके, तो आप लोग यहीं रहिए ना, तो हमको पता कैसे चलेगा? अच्छा अच्छा, ठीक। ओके गाइस, सो आई होप कि कुछ इम्प्रूवमेंट हुआ हो, दे आर वर्किंग ऑन इट। सो GQ is going to remember the mnemonic maths, and maths stand for M1, M3, M5, all the odd numbers. A stand for your AT1, A stand for your alpha 1, AT1, alpha 1. T stand for your TSH, H for histamine, histamine का कौन सा? अगेन 1, and serotonin का इकलौता serotonin, because all the other two are going into GI, and this is going to be your 5HT2. This is going to be 5HT2. Again there is a lagging. Okay, so maths is a very very simple mnemonic. Maths. स्टार्ट करें. All right. I hope it's clear now. Is it fine? मेरा फ़ोन भी उन्हीं के पास है शायद. ओके. सो बादशाह एडॉम्स की मैथ्स इज क्वेश्चनेबल है ना. तो BDSH बादशाह एडॉम्स विल बी ऑल द आई एंड मैथ्स इज क्वेश्चनेबल. दैट मीन्स GQ वाले वो सारे हो गए. ठीक है. नाउ G प्रोटीन का पॉलिसैकेराइड इज नॉट द फास्टेस्ट इज द आयन चैनल. बीटा component is the active one, no, alpha is the active one. And upon the activation, the subunit break down into alpha and beta gamma. Alpha is the one that is getting separated from beta and gamma, and then alpha does its activity by stimulating either adenylate cyclase enzyme, inhibiting adenylate cyclase enzyme, or by increasing the phospholipase C activity. Next one. A 35-year-old male is started on typical antipsychotics. सही हो गया. Typical antipsychotics that we have. Okay. बच्चे तो बोल रहे हैं still lagging. Hi guys, is everything is fine now? Can you give a quick confirmation? All the students, those who are live. Audio good now? ठीक है सब. Okay, great. So a 35-year-old male is started on typical antipsychotics. All the typical antipsychotics are mainly D2 blocker. Later he developed a motor restlessness. Okay, so all the D2 antagonists, they are going to be associated with the extrapyramidal symptom like your dystonia, है ना, akathisia. Akathisia is a motor restlessness without source of anxiety. It is the motor restlessness without the source of anxiety, है ना. Secondary Parkinsonism, न्यूरोलेप्टिक मैलिग्नेंट सिंड्रोम एंड एक लेट ऑनसेट एक्स्ट्रापिरामिडल सिम्टम होता है जिसको बोलते हैं टार्डिव डिस्काइनेशिया. यू आर ऑल्सो हैविंग वन मोर नोन एज टार्डिव डिस्काइनेशिया. ठीक है, टार्डिव डिस्काइनेशिया. सो दीज आर द वन दैट वी आर हैविंग. डिस्टोनिया, akathisia, secondary Parkinsonism, है ना, न्यूरोलेप्टिक मैलिग्नेंट सिंड्रोम एंड टार्डिव डिस्काइनेशिया. राइट. सो दीज आर द वन दैट आर कंसिडर्ड एज अ एक्स्ट्रापिरामिडल सिम्टम एंड एग्जामिनर सेइंग मोटर रेस्टलेसनेस विदाउट द सोर्स ऑफ एंजाइटी आफ्टर स्टार्टिंग द टिपिकल एंटीसाइकोटिक्स. ड्रग ऑफ चॉइस, सो दे आर मेनली टॉकिंग अबाउट akathisia बिकॉज akathisia का जो ड्रग ऑफ चॉइस होता है दैट इज गोइंग टू बी प्रोप्रानोलॉल. डिस्टोनिया के लिए वी कैन यूज सेंट्रली एक्टिंग एंटीकोलिनर्जिक ड्रग लाइक बेंजहेक्सोल, or we can also utilize drugs like promethazine. Likewise, same kind of drug we can also use for secondary Parkinsonism. And neuroleptic malignant syndrome के लिए we can use a specific antidote that is bromocriptine. And bromocriptine के साथ we can even add dantrolene as well. bromocriptine के साथ specific dantrolene हम use कर सकते हैं, but a specific antidote is going to be bromocriptine for the neuroleptic malignant syndrome, है ना. Tardive dyskinesia we can utilize vesicular monoamine transporter 2 inhibitor, VMAT2 inhibitor, and VMAT2 inhibitor that we have, it will be drugs like your valbenazine, deutrabenazine. In addition to this, for this we can also utilize your drugs like your benzodiazepines. ठीक है. So this is again typical antipsychotics है. तो we can utilize propranolol as a drug of choice. Fluoxetine is one of the SSRI used as an antidepressant. Lithium is a drug of choice for mania. It has no role here. Haloperidol that we have, it is also going to be typical antipsychotics. And if you use this typical antipsychotic, they will further worsen the problem of extrapyramidal symptom. So anyway, this is not used. Haloperidol is not used. So again, in this case scenario, the drug of choice is going to be propranolol. A 50-year-old psychotic patient was started on antipsychotic drug. He now presents side effect like priapism, peripheral edema and cataract. So again, typical antipsychotics में एक ड्रग आता है जिसका नाम होता है क्यूटियापीन. And in our classes we always discuss this, that क्यूटियापीन comes at the place of queen. It's like a queen. और एक ऐसी क्वीन जो अंधी थी, अंधी रानी मैं बोलता हूँ. अंधी रानी इसलिए बिकॉज उस क्वीन को था कैटरैक्ट. And other side effect like priapism can also be noted. So remember andhirani, so quetiapine is the one that is going to be the correct answer for this one. Ziprasidone, aripiprazole, ziprasidone, they are little away from their actual characteristic. What do you mean by actual characteristic? टिपिकल एंटीसाइकोटिक्स का एक्चुअल कैरेक्टर ये है कि दे आर सपोज टू कॉज weight gain, metabolic syndrome. The typical antipsychotics, remember, typical antipsychotics, these typical antipsychotics, they are mainly supposed to cause, or typical antipsychotics are mainly associated, atypical, typical to extrapyramidal symptom I told you, atypical antipsychotics are associated with the metabolic syndrome, weight gain, डिसलिपिडीमिया, ये सारे के सारे इनके साथ साइड इफेक्ट एसोसिएटेड हैं. बट देर आर टू दैट इज नॉट फॉलोइंग द रूल, दे आर गोइंग अगेंस्ट द रूल. And when someone is going against the rule, then two people will definitely talk about them. And you can talk like this: अरे शिप्रा को देखा क्या, she is not gaining weight, she is still running slim shot. अरे शिप्रा को देखा, वो बड़ी slim shot है. तो they are the one that is associated with the less weight gain. Clozapine as a drug, remember, they are the first anti-suicidal drug. Clozapine is the first anti-suicidal drug. Clozapine is the drug of choice in a patient with the resistant psychosis. It is the drug of choice in a patient with the resistant psychosis, and clozapine is a drug is also going to be associated with a very important side effect like agranulocytosis. They are very dangerous side effect. Counts are markedly low. Agranulocytosis, not leukopenia, agranulocytosis, much severe. ठीक है, agranulocytosis, साइलोरिया जिसको हम बोलते हैं वेट पिलो सिंड्रोम, excessive salivation, sialorrhea, sedation, seizure, all these side effects can be seen. In addition to that, there will also be myocarditis. That is also going to be one of the important side effects. So sialorrhea, sedation, seizure, myocarditis, all these are side effects of the clozapine, and clozapine is also one of the frequently asked drug in your examination. Now clozapine will also be associated with all these side effects like weight gain wala side effect, metabolic syndrome wala side effect. This will all be seen with the clozapine. So this weight gain and all maximally seen with your olanzapine, क्लोजापिन, क्यूटियापिन. तो अगर आप ड्रग को ध्यान से देखेंगे तो व्हाट यू विल रियलाइज दैट ऑल ऑफ देम आर हैविंग अ फिगर 0. ओ आपको आलू के जैसा बना दे, ओ आलू फिगर 0 बड़ा सा. सी अ फैमिली पैक. क्यू अगेन बड़ा सा, है ना. तो ये सारे के सारे मैक्सिमली एसोसिएटेड विद वेट गेन है. बट विच वन इज हैविंग लेसर रिस्क ऑफ वेट गेन, दैट इज गोइंग टू बी, अरे शिप्रा को देखा वो तो बड़ी स्लिम है, जिप्रासिडोन. एंड दिस वाज आस्क्ड इन वन ऑफ द बोर्ड एग्जामिनेशन ऑफ 2024 जनवरी में जो हुआ था. ठीक है. Which of the following anti-epileptic drug can cause megaloblastic anemia and increasing the risk of fracture, gum hypertrophy? I think ये ड्रग देखते ही सब लोग इसका सही जवाब दिए होंगे, गम hypertrophy. That is going to be phenytoin. Reason being that phenytoin is having inhibiting property of the enzyme collagenase. Collagenase normally does what? Collagenase, it causes breakdown of the collagen. So what does collagenase does? Collagenase normally it is going to cause collagen का breakdown. Collagen का breakdown करता है कौन? Collagenase. If collagenase itself is inhibited, what will happen to the level of collagen? This collagen deposition will increase, and because of the excessive collagen deposition, the patient will present to you with the gum hypertrophy, and this gum hypertrophy in fact considered the most common side effect. Remember, this is one anti-epileptic drug that is also having wound healing property. So already you have the idea, right, how wound healing property will be seen, right? They are going to be wound healing property. They are going to have wound healing property. Why? Because again collagen deposition will increase. ठीक है. They are also going to decrease the calcium absorption, vitamin B12 का absorption. They will be interfered, and because of that they can lead to increasing the risk of fracture. They can also lead to megaloblastic anemia. And one of the USMLE question that was asking around 1920 के आसपास में, that which of the following anti-epileptic drug that is causing decrease in the deep tendon reflexes. So again, because of the megaloblastic anemia, there will be decrease in the deep tendon reflexes. ठीक है? So I hope that all of you guys have got this one. That anti-epileptic drug. Remember, phenytoin is also one of the antiarrhythmic drug. Phenytoin as a drug, it is a drug that follows zero order kinetics. Question number 1. It's a drug that is a very, very potent enzyme inducer. Question number 2. It is an anti-epileptic drug also having antiarrhythmic property. Antiarrhythmic property, class 1B antiarrhythmic property. I am talking only and only about phenytoin here. And I have given you the reason why they are causing gum hypertrophy, megaloblastic anemia, or increasing the risk of fracture. Okay? Other drugs, if you see, barbiturate, they are also enzyme inducer. Barbiturates, है ना? They are a highly toxic drug, है ना? काफ़ी इनका जो safety margin होता है काफ़ी narrow होता है. Carbamazepine, it is mainly associated with problems like rash, bone marrow suppression, agranulocytosis, ठीक है, rash that is occurring secondary to Stevens-Johnson syndrome, agranulocytosis, bone marrow suppression. All these are the important side effect of your carbamazepine. Valproate is a highly hepatotoxic drug. ठीक है. Plus they are also associated with other side effects like weight gain, tremor, alopecia. All these are side effects that has been associated with the valproate. Hepatotoxicity, weight gain, tremor, alopecia. ठीक है. Gender specific side effect called polycystic ovarian syndrome. And isn't that we have already just read that peacock वाला आएगा inhibit करके जाएगा. That means this is one of the potent enzyme inhibitor. Valproate is one of the potent enzyme inhibitor. All other anti-epileptic enzyme inducer, this is one of the enzyme inhibitor anti-epileptic drug. Okay. Next one, anti-epileptic agent causing weight gain, thrombocytopenia, and polycystic ovarian syndrome. So in the previous question only, we have discussed this already. The name of the drug is going to be your valproate. About topiramate, I used to tell you that topiramate is a very, very holistic drug. It wears topi and does all the good work. What do we mean by wears topi and does all the good work? Holistic drug hai, wear topi. That means it's an anti-epileptic drug used in generalized tonic-clonic seizure. It can be utilized in partial seizure. It can also be utilized in Lennox-Gastaut syndrome. In all type of epilepsy we can use. Again, anti-epileptic drug. It is also going to be utilized in a patient with a bipolar disorder. It can also be utilized as an anti-epileptic drug, bipolar disorder, and they also can be utilized for decreasing the craving of alcohol. So again, it's a holistic drug. तो टोपी पहन के ये अल्कोहल भी नहीं पीने देगा, decrease the craving of alcohol. Plus they can also be utilized for the prophylaxis of migraine. तो देखिए हेडेक भी नहीं देगा, ठीक है, हेडेक भी नहीं देगा. एंड एज एन एंटी ओबेसिटी ड्रग ऑल्सो, फॉर द ओबेसिटी के ट्रीटमेंट में भी ऑल्सो वी कैन यूटिलाइज बिकॉज दे आर कॉजिंग वेट लॉस, है ना. तो देखिए बहुत सारी चीज़ें ABCMO या ABCMO, हाँ, तो A से एंटी एपिलेप्टिक ड्रग, B से बाइपोलर डिसऑर्डर, C से क्रेविंग ऑफ एल्कोहल विल बी रिड्यूस, MO इज माइग्रेन का प्रोफिलैक्सिस, एंड ओबेसिटी के लिए भी यूज़ कर सकते हैं. तो अगेन देयर आर मेनी यूजेस. एंड टोपी वाले को मैं बोलता हूँ ये टोपी वाला ड्रग है, एंड टोपी पहन के सारे अच्छे काम करता है. तो देखिए सर दर्द नहीं देगा, वेट नहीं देगा, एल्कोहल नहीं पीने देगा, बाइपोलर में भी हेल्प है, एंटी एपिलेप्टिक तो इट्स स्टिल देयर, ठीक है. Next is going to be a patient with a history of epileptic disorder started with rufinamide. Rufinamide. How to remember? Rufinamide, receptor number 5 inhibitor. इसको मैंने अलग अलग लिख दिया. Rufinamide, very very easy. Receptor number 5. So they are actually mGlu5 receptor blocker. mGlu5 receptor blocker. So mGlu5 receptor inhibitor. mGlu5 receptor is a receptor for, it's a receptor for glutamate. So they are actually glutamate receptor, and we know glutamate causes excitotoxicity of the neuron. Synaptic vesicular protein inhibitor, that is SV2A inhibitor. SV लीवी, मैं बार बार बोलता हूँ एसवी लीवी साउंड्स लाइक अ बीवी, सो ब्रिवारासिटाम, एसवी लीवी बीवी, levetiracetam. Then we are also having brivaracetam, SV लीवी बीवी, levetiracetam, brivaracetam. और एक ऐसी बीवी जो प्रेग्नेंट है उसमें ड्रग ऑफ चॉइस भी होगा, आई यूज टू टेल यू. सो दे आर द ड्रग ऑफ चॉइस फॉर epilepsy in pregnancy. Drug of choice for epilepsy in pregnancy, the name of the compound is SV2A inhibitor. The name of the compound is SV2A inhibitor. SV लीवी है ना, and BV, SV लीवी and BV. ठीक है. ड्रग ऑफ चॉइस फॉर एपिलेप्सी इन प्रेगनेंसी दैट इज गोइंग टू बी लेवेटिरासेटाम एंड ब्रिवारासेटाम. एंड इसके साइड इफेक्ट भी बीवी वाले होते हैं, उसको भी देख लेते हैं. बीवी वाले साइड इफेक्ट मतलब एक प्रेग्नेंट बीवी जो कि अगेन ड्रग्स पे है, शी विल कीप ऑन स्लीपिंग, somnolence. Other side effect will be your anger, aggression. क्यों एंग्री है नहीं पता है, क्यों एग्रेसिव है नहीं पता है, ऑलवेज एजिटेटेड, बेचारे पुअर हस्बैंड पे उसको भी नहीं पता है क्यों एजिटेटेड है, एंशियस भी रहती है, एंड शी इज मोस्ट ऑफ द टाइम इरिटेबल ऑल्सो. शी इज द इरिटेबल ऑल्सो मोस्ट ऑफ द टाइम. सो अगेन बीवी वाले सारे साइड इफेक्ट हो गए. एसवी लीवी बीवी, इसीलिए तो मैं बोलता हूँ इसको कहानी की तरह याद रखिए. द फार्माकोलॉजी विल बी रिमेंबर्ड लाइक अ स्टोरी. एसवी लीवी बीवी, लेवेटिरासेटाम, ब्रिवारासेटाम, ठीक है, एंड लीवी बीवी हो गया. देन बीवी वाले साइड इफेक्ट और यूजेस भी हो गया. बीवी जो प्रेग्नेंट, हस्बैंड तो प्रेग्नेंट हो नहीं सकता, वी डोंट हैव दैट टेक्निक येट. एनीवेज, डायरेक्ट गाबा ब्लॉकर, गाबा रिसेप्टर ब्लॉकर है ना. We have some drugs that act on the GABA mediated chloride channel, but rufinamide is not a GABA blocker. And calcium channel blocker, we have drug that is your pregabalin and gabapentin. So which type of calcium will be blocked by them? Pregabalin, gabapentin, they are the N-type calcium channel blocker. Neuronal type of calcium channel blocker will be caused by pregabalin, gabapentin. ठीक है. Next, drug of choice for myoclonic epilepsy in children. Myoclonic epilepsy, हमेशा ध्यान रखिए, drug of choice is going to be valproate. Ethosuximide is the drug of choice in a patient with the absence seizure. Valproate is also the drug of choice in a patient with the atypical absence seizure. Atypical absence seizure. Myoclonic मैं आपको बता चुका हूँ ऑलरेडी, वो क्वेश्चन ही है. It is also the drug of choice in a patient with the atonic seizure, clonic seizure, myoclonic seizure, Lennox-Gastaut syndrome, Dravet syndrome. In all these conditions, sodium valproate will be considered the drug of choice. It is also preferred first line in GTCS, but lamotrigine is more preferred due to its lesser hepatotoxicity. They are the drug of choice in GTCS, but other drug like valproate can also be used. Other drug like valproate can also be used. They are going to be the drug of choice in patient with a neonatal seizure. Some other drug of choice you might be thinking is a revise ho jaye. So remember, we have carbamazepine, that is the drug of choice in patient with the partial seizure. It's also the drug of choice in patient with a trigeminal neuralgia and glossopharyngeal neuralgia, TNGN. TNGN मतलब trigeminal neuralgia and glossopharyngeal neuralgia. In both the scenario, carbamazepine is considered as a drug of choice. ठीक है. तो जनरलाइज सीजर भी हो गया, पार्शियल सीजर भी हो गया. समटाइम वी ऑल्सो गेट द क्वेश्चन वेरी फ्रिक्वेंटली ऑन इन्फेंटाइल स्पाज्म. फॉर इन्फेंटाइल स्पाज्म वी यूज ACTH. हाउएवर समटाइम इन्फेंटाइल स्पाज्म विद द ट्यूबरस स्क्लेरोसिस वी यूज vigabatrin. Vigabatrin, remember, it's one of the GABA transaminase inhibitor. Vigabatrin is one of the GABA transaminase inhibitor. What is IS? Infantile spasm with the tuberous sclerosis. ठीक है. Epilepsy in pregnancy I have already covered in the previous question that levetiracetam, brivaracetam will be preferred for epilepsy in pregnancy. Which drug has been approved very recently for the treatment of opioid-induced constipation without precipitating the withdrawal symptom? So we have a class of drug, we call them as a peripherally mu-opioid receptor antagonist. Peripherally mu-opioid receptor antagonist, the drugs under this one are going to be MAN. This stand for your drugs like your methylphenidate, Lvmopan, methylphenidate, Lvmopan, and other one is known as your naldemedine. ठीक. Now these are peripherally acting mu opioid receptor antagonists. Naloxone is also mu opioid receptor antagonist, but they can precipitate the withdrawal symptom. So if the examiner is asking that without precipitating the withdrawal symptom, which of the following drug you can use? So without precipitating the withdrawal symptom, the drug that you are going to use will be your Lvmopan. Naloxone, nalmefene, they are all opioid antagonists. They can be utilized as an antidote of opioid poisoning, antidote of the opioid. Opioid poisoning antidote होता है naloxone, IV route से we can give easily. Lacosamide is a voltage gated sodium channel blocker. Studies have shown that it is also one of the anti-epileptic drug होता है. Lacosamide is an anti-epileptic drug, AET anti-epileptic drug. It's also one of the CRMP protein inhibitor, collapsin response mediated protein, that is actually going to decrease the excitotoxicity of the neuron. That decreases the excitotoxicity of the neuron. So MAN is a very simple mnemonic to remember. Peripherally acting mu opioid receptor antagonist. They can be utilized for the treatment of the opioid induced constipation without precipitating withdrawal symptom. Can we use naloxone? Yes. But question यहाँ ये नहीं पूछ रहा कौन से यूज कर सकते हैं, करेंगे, पूछ रहा है which can be used without precipitating the withdrawal symptom, that is peripherally acting mu opioid receptor antagonist Lvmopan. 40-year-old chronic alcoholic patient started on a drug for his addiction. After intake of a drug, he consumed alcohol. So remember, there are drugs that are acting like disulfiram. There are drugs that are acting by disulfiram, or we call them disulfiram-like reaction, because disulfiram is one of the aldehyde dehydrogenase inhibiting property. And when you inhibit aldehyde dehydrogenase, there will be increase in the level of a toxic intermediate metabolite by the name of acetaldehyde. This toxic intermediate metabolite aldehyde, they are going to be associated with problems like nausea, vomiting, there will be flushing episode, headache, fall in the blood pressure, abdominal pain, lot of pain. The patient will give you the feeling like or specific history like, doctor, I felt like as if I'm going to die. ऐसा लगा मैं मरने वाला हूँ. Because very uneasy feeling will be there if ever there is an increment in the acetaldehyde. That's why we always say that you give disulfiram only after informing the patient. चुपके से नहीं देना है, ठीक है? Disulfiram. There are other drugs that are having disulfiram-like reaction. Other drugs that are showing disulfiram-like reaction, and we call them as a Government Medical College of Madhya Pradesh and Chhattisgarh. So Government Medical College stand for your Griseofulvin, one of the antifungal drug. Griseofulvin, one anti-amoebic drug, metronidazole. तो ये क्वेश्चन भी बार बार आता है. A patient is on anti-amoebic drug, now consumed alcohol, what kind of problem is seen here? So we call them a disulfiram-like reaction. Or recently 2024 January में there was a question, a patient was given a drug for amoebic liver abscess or cyst, and now he consumed alcohol. What kind of reaction will be seen? So you already know the type of reaction that will be seen. उसको हम बोलेंगे disulfiram-like reaction. क्या नाम देंगे उसको? Disulfiram-like reaction. And C stand for your C4010, which is a very beautiful watch. C4010, ठीक है? Cefoperazone, C4010, cefoperazone, cefomandole, ठीक है? Other drugs are going to be Madhya Pradesh and Chhattisgarh. So गवर्नमेंट मेडिकल कॉलेज और मध्य प्रदेश और छत्तीसगढ़ में आपको वो अल्कोहल वाले साइड इफेक्ट मिलते हैं. मध्य प्रदेश स्टैंड फॉर योर cephalosporin that is banned now. We call them as a moxalactam, procarbazine, or anti-cancer drug by the name of procarbazine. It's one of the cell cycle non-specific agent, alkylating agent में आते हैं. And other one is going to be chloropropamide, which is a first generation sulfonylurea. Chloropropamide for generation sulfonylurea. So these are all the drugs that are showing disulfiram-like reaction. These are all the drugs showing disulfiram-like reaction. गवर्नमेंट मेडिकल कॉलेज ऑफ मध्य प्रदेश एंड छत्तीसगढ़ में आपको ये अल्कोहल वाले सारे के सारे साइड इफेक्ट मिलते हैं. ठीक है, तो अगेन रिमेंबर ये डाइसल्फिराम से रिलेटेड सारे क्वेश्चन सॉल्व हो गए एंड दे आर गोइंग टू एडमिट विच एंजाइम. एल्डिहाइड डिहाइड्रोजिनेस ए इज द करेक्ट आंसर फॉर दिस वन. एल्डिहाइड डिहाइड्रोजिनेस. A 33-year-old manic patient was started on lithium. Which of the following is the least likely adverse effect? So lithium, even at the therapeutic dose, will be associated with the side effect remembered by the mnemonic LIT. They can cause leukocytosis. They can cause insipidus. Insipidus का मतलब हो गया डायबिटीज insipidus की बात कर रहे हैं. Tremor initially will be seen fine tremor. Later on, it can turn out to be coarse tremor at the toxic doses. They can also be associated with teratogenic effect, which most of you guys are already aware. They can be associated with the Epstein anomaly. And they can also cause hypothyroidism. मैं अभी toxicity की बात ही नहीं कर रहा हूँ. Even at the therapeutic dose, they can be associated with all the side effects that is remembered as the mnemonic LITTH. Lithium का side effect remembered by lithium. So because there is diabetes insipidus, don't you think the patient will have polyuria, polydipsia? Is there a hyper or hypo? Least likely. So hyper नहीं होगा, hypo होगा ना. ल्यूकोसाइटोसिस हो गया ना, ल्यूकोसाइटोसिस हो रहा है, ट्रेमर भी हो रहा है. बट लीस्ट लाइकली अगर पूछ रहा है तो हाइपरथायरॉइडिज्म नहीं होगा, हाइपो होता है. ऑल ऑफ द फॉलोइंग आर फ्रॉम TCA क्लास एक्सेप्ट. सो TCA मतलब ट्राईसाइक्लिक एंटी डिप्रेसेंट. We have drugs like your imipramine, trimipramine. All the students, those who are live, you can keep on commenting on the answers. Trimipramine, trimipramine, desipramine, clomipramine, imipramine, trimipramine, desipramine, clomipramine, amitriptyline, and nortriptyline. Now you can remember tricyclic. Tri मतलब होता है 3. Tri means होता है क्या? 3. So the story goes like this: that tricyclic antidepressant that I try a desi club for my 2 girlfriends or for my 2 friends. गर्लफ्रेंड कहना गलत हो जाएगा. फॉर माई 2 फ्रेंड्स आई ट्राई अ देसी क्लब फॉर माई 2 फ्रेंड्स नोन एज एमी एंड नोरा. अब आप जिस भी नोरा को समझ लो. जस्ट रिमेंबर आई एम ट्राइंग फॉर 2 more people. So I myself and will become 2 more. So it will become total 3. So we are talking about tricyclic antidepressant. I try a desi club for Amy and Nora. I imipramine, trimipramine. Desi club will be desipramine, clomipramine, amitriptyline, nortriptyline. So very simple. You can see that venlafaxine is one of the SNRI group का drug. वेनिला डुअल स्माइल. बोलता हूँ ना वेनिलाफैक्सिन, डुलोक्सिटिन, मिलनासिप्रान, लिवोमिलनासिप्रान. तो वेनिला लेकर जाना, आपका प्यार दुगना होगा. वेनिला डुअल स्माइलव इज द निमोनिक टू रिमेंबर ऑल द SNRI. वेनिलाफैक्सिन, डुलोक्सिटिन, मिलनासिप्रान, लिवोमिलनासिप्रान. ठीक है. ऑल ऑफ द फॉलोइंग आर ट्रू अबाउट ARB एक्सेप्ट. कैंडी साटान कैन बी यूज्ड इन द माइग्रेन प्रोफिलैक्सिस. यस, कैंडी खाने से सर दर्द दूर हो जाता है. एक बात याद रख लीजिएगा. और दूसरा, candy has the highest affinity for AT1 receptor. They have the highest affinity for angiotensin 1 receptor, AT1 receptor. Low sartan, it lowers everything. So low sartan, it has the lowest T half life. हाँ जी. Low sartan, it also lowers the platelet का aggregation because of the thromboxane A2 inhibiting property. Low sartan, it also lowers the LDL level. Low sartan, it also lowers the uric acid level because of the uricosuric property. So low sartan हर चीज़ को lower करता है. Low sartan हर चीज़ को lower करता है. Irbesartan induces PPAR alpha, है ना, याद है. अल्फा फा फी, क्या बोलता हूँ मैं? फा Phi. So all the fibrates are coming under as a PPAR alpha agonist. So remember Pha Phi. All the PPAR alpha agonists are coming as a, है ना. fibrates like fenofibrate, bezafibrate, gemfibrozil. So all of them are going to be fibrates. So the PPAR gamma that we have, some ARB are having PPAR gamma agonistic property, and earlier we had the information only about telmisartan, and question on telmisartan has already been asked twice. But recent papers are saying that in addition to telmisartan, irbesartan and losartan, it goes in the same order, TIL, इसी order में जाते हैं, telmi, irbe, losartan, they are also having PPAR gamma. Gamma say glucose, you have to remember, and they will be increasing the insulin sensitivity. So remember PPAR gamma agonist, PPAR gamma agonist. So not अल्फा तो फाइब्रेट वाले होते हैं ना, तो इर्बेसार्टन का भी होता है, एंड कैंडीसार्टन हैज मैक्सिमम एफिनिटी, यस दैट्स आल्सो ट्रू. Which of the following is a reversible P2Y12 inhibitor? So under reversible, if you want to remember, then there is something called irreversible also. Irreversible कौन से हैं? टिक्लोपिडीन, जिसको हम नहीं यूज करते हैं बिकॉज ऑफ हाई रिस्क ऑफ न्यूट्रोपीनिया. देन वी हैव टिक्लोपिडीन, क्लोपिडोग्रेल, ticlopidine, clopidogrel, and other one is a prasugrel. So their name is mainly ending with what? Grel, 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 grill, grill, है ना. So grill की बात करेंगे जहाँ पे, तो रिवर्सिबल आ गया. तो एक है कैंग्रिलॉर, इसके नाम में ग्रिल तो आ रहा है, लेकिन ये बोल रहा है कैंग्रिलॉर रिवर्सिबल होंगे. अगला है टिक्का ग्रिलॉर, विच साउंड्स लाइक अगेन ग्रिल्ड फूड, चिकन टिक्का ग्रिलॉर. तो चाहे चिकन टिक्का हो, पनीर टिक्का हो, कैसे लेते हैं आप? ओरली लेते हैं. सो दे आर द ओरल वन. कैंग्रिल और कैनुला वाला है, सो दे आर गिवन बाय द इंजेक्टेबल रूट. ठीक है, कैनुला से देंगे कैंग्रिलॉर, दे आर द रिवर्सिबल. टिक्का ग्रिलॉर टिक्का होगा लाइक पनीर टिक्का, चिकन टिक्का, दैट इज गोइंग टू बी रिवर्सिबल. सो आई थिंक यू कैन इजीली रिमेंबर रिवर्सिबल P2Y12 इनहिबिटर इज गोइंग टू बी योर कैनुला वाला कैंग्रिलॉर. टिक्लोपिडीन, दैट इज टिक्लोपिडीन दैट वी हैव, दे आर गोइंग टू बी irreversible. Clopidogrel, prasugrel is also irreversible. We are not using ticlopidine. The reason being ticlopidine we are not using because they are associated with the neutropenia. Ticlopidine, ठीक है, ticlopidine. Which of the following agent is used for the reversal of the rivaroxaban? Now, what is rivaroxaban? First you understand and then you will remember the drug forever. Rivaroxaban, ये 10A को बैन लगाते हैं. They are the direct 10A inhibitor. For example, I can give you Apixaban. Let me write this drug name like this, Apixaban. Deliberately I am writing थोड़ा छोटा थोड़ा बड़ा, तो you can remember ये 10A पे बैन लगाते हैं. Now you take any name, Apixaban, Betrixaban, Rivaroxaban, Edoxaban, all of them are having 10A पे बैन लगाने की कैपेसिटी. And if there is any overdose of 10A, then to neutralize this we have an antidote. To neutralize the antidote, and antidote is also like this, 10A को न्यूट्रलाइज करने वाला ड्रग एंडिक्सानेट अल्फा. 10A को न्यूट्रलाइज करने वाला ड्रग, दैट विल बी एंडिक्सानेट अल्फा. आई थिंक इट्स प्रीटी सिंपल. प्रोटामीन सल्फेट इज द एंटागोनिस्ट और एंटीडोट फॉर हेपारिन. इदारुसीजुमाब, दारू मोनोक्लोनल एंटीबॉडी है. और मैं बोलता हूँ डेबिगेट्रान, दबा के दारू. व्हाट इज डेबिगेट्रान? सी, डेबिगेट्रान इज ओनली दैट इज ओरली इफेक्टिव डायरेक्ट 2A inhibitor. Orally effective, that is direct 2A inhibitor. All other 2A inhibitor are injectable. Andixanet alpha is the correct answer. Fresh frozen plasma or vitamin K1, they will be utilized if there is any warfarin ka overdose. Next question or another question that has been asked about streptokinase overdose में we are going to use epsilon aminocaproic acid and also other one is your tranexamic acid. Epsilon aminocaproic acid and other one is known as your tranexamic acid, EACA. Epsilon aminocaproic acid or tranexamic acid. Preferably specific antidote is epsilon aminocaproic acid. In one of the INI-CET, they give the same 5 drugs and their antidote, and they ask you to do the match the following, match the correct antidote, match the correct antidote का क्वेश्चन आया था. Mechanism of action of recently approved drug Pritomanid. तो इसके पहले मैंने जो प्रेडिक्ट किया था वो ये था अबाउट माइकोलिक एसिड सिंथेसिस इनहिबिटर, एंड वी हैव 2 इंपॉर्टेंट ड्रग दैट इज नोन एज योर बेटाक्विलिन, है ना, बी से बेटाक्विलिन देखिएगा, बी के बाद एक आता है ए और या ए के बाद आता है बी, सो दे आर द एटीपी सिंथेज इनहिबिटर. And manid, pretomanid, and we have one more delamanid. So because betaquilin has already been asked, next potential MCQ could be manid and manid. So M for manid, they are the mycolic acid synthesis inhibitor. Mycolic acid synthesis inhibitor. ATP synthesis inhibitor will be betaquilin. Both of these agents, चाहे delamanid हो चाहे betaquilin हो, they are associated with some common side effect like QT prolongation, hepatotoxicity, and electrolyte imbalances. Inhibit RNA polymerase. This RNA is dependent on the DNA, so we call DNA dependent RNA polymerase, and this will be done by none other than your rifampicin. This will be rifampicin. ठीक है. Isoniazid actually require their activation. The active form of isoniazid is going to inhibit the mycolic acid synthesis. They also inhibit the mycolic acid synthesis, and mycolic acid synthesis means they will also be having cidal property. So they require their activation with the help of enzyme called catalase peroxidase. They require their activation with the help of enzyme catalase peroxidase. This catalase peroxidase is encoded by a gene called Katrina G wala gene. कौन सा gene? Katrina G wala gene. It actually encodes Katrina G wala gene, it actually encodes your catalase peroxidase. So catalase peroxidase is essential for the action of which antitubercular drug? Isoniazid. Catalase peroxidase is essential for the action of the isoniazid. Which ATT drug causing hypothyroidism? Now there are two drugs that has been associated with hypothyroidism: para-aminosalicylic acid and other one is your ethionamide. These are the two important drugs that has been associated with the hypothyroidism. ठीक है. So cycloserine is going to cause a neuropsychiatric side effect. जो आपको साइक बना दे ऐसा है ये सेरीन. So इसलिए मैं इसको बोलता हूँ न्यूरोसाइकेट्रिक साइड इफेक्ट विल बी साइक है ये सेरीन. ethambutol, थम जाना इज रुक जाना. दे आर फर्स्ट एंड फॉरमोस्ट स्टैटिक एंटी ट्यूबरकुलर ड्रग एसोसिएटेड विद ऑप्टिक न्यूराइटिस, and they can also cause increase in the uric acid level. This explains the fact that in the recent 2023, why there was a question asked that drug, ATT drug, anti-tubercular drug that is causing gout ka precipitation, which anti-tubercular drug that is going to cause precipitation of the gout? So one will be very important drug जो मैं बोलता हूँ कि टू मच प्यार दर्द भी देता है, तो पायराजिनामाइड को मैं बार बार बोलता हूँ प्यारजिनामाइड, एंड पायराजिनामाइड ये आपको दर्द भी देगा. प्यारजिनामाइड, पायराजिनामाइड इज प्यारजिनामाइड, प्यार दर्द भी देगा. एंड वेन एवर प्यार इज गोइंग टू गिव यू दर्द, रिमेंबर इंपॉर्टेंट थिंग, जब भी ये दर्द दे दे तो उस कंडीशन में क्या करते हैं? इफ देर इज अ प्रेसिपिटेशन ऑफ द गाउट, देन यू आर सपोज टू स्टॉप and increase the duration of therapy with HRE into 9 month. उसको 9 मंथ के लिए कर दीजिए. सो अगर आपको पता चल गया कि दिस प्रेसिपिटेशन ऑफ गाउट इज अगेन मेनली बिकॉज ऑफ दिस ड्रग प्यारजिनामाइड, तो आप उसको बंद करके HRE को कंटिन्यू करिए. ठीक है. इथियोनामाइड इज ऑल्सो वन ऑफ द ड्रग. सो वन ड्रग इज कॉजिंग प्रेसिपिटेशन ऑफ गाउट and ethambutol, sorry, other one is your ethambutol. They can also cause precipitation of the gout. But again दोनों में सबसे ज़्यादा कॉमन कौन होगा? That will be your pyrazinamide. Rifampicin is going to cause a red orange urine discoloration. They are going to also be hepatotoxic in nature. Red orange urine, hepatotoxicity and flu-like symptom. Rifampicin ये वही ड्रग है बच्चे which was mainly potent enzyme inducer. The drug quinine act by, quinine is one of the drug that is going to act by heme polymerase inhibition. Now what is heme polymerase inhibition? Let's understand. Parasite on the RBC is mainly surviving on the hemoglobin. Parasite in the RBC is surviving on hemoglobin. So wherever there is a hemoglobin, this will be broken down into two important parts. One will be your heme and other one will be globin. एक यूजफुल है, एक टॉक्सिक है. Heme is toxic to the parasite, and globin is on which parasite is going to feast, and parasite is going to survive on the globin. Now, when the parasite came to know, okay, there is someone by the name of heme which is toxic to us, they can actually not allow our survival. They said, okay, we should give an enzyme by the name of heme polymerase that will be causing metabolism of the heme. Globin will be utilized by the parasite. It will be utilized by parasite. So when someone get to know about this, when someone got to know that okay, heme polymerase is causing metabolism of heme, so that heme is becoming non-toxic. Heme is actually toxic to the parasite. It is actually toxic to the parasite. So what you do, you actually inhibit the heme polymerase. So now the level of heme will increase, and that will be causing toxicity for the parasite. और हीम से आपको याद आता है ब्लड आपको याद आता है, तो रिमेंबर मैं बोलता हूँ कि लॉन्ग एमसीक्यू जो होते हैं वो आपका खून जला देते हैं. लॉन्ग एमसीक्यू दे बर्न योर ब्लड. दैट स्टैंड फॉर ड्रग्स लाइक योर लुमिफेंट्रिन, मेफ्लोक्विन. लुमिफेंट्रिन के साथ एक और आता है हेलोफेंट्रिन, which also causes QT prolongation as a side effect. Lumifantrin, halofantrin, mefloquine, chloroquine, and other one is the quinine. So these are the drugs that are known as long MCQ जो आपका खून जलाते हैं, और ये सारे के सारे क्या है? All of them are heme polymerase inhibitor. Heme polymerase inhibitor. Gametocytic will be associated with the primaquine, है ना? Primaquine, है ना? Atovaquone inhibit the mitochondrial function. Mitochondria, because mitochondria is the one that is generating the energy. So atovaquone, atto is mito, atovaquone, it interfere with the mitochondrial function. Interfere with the mitochondrial function. MT is mitochondrial function. And artemisinin group के जितने भी drug हैं, they are derived from the traditional Chinese medicine. So I used to say that Chinese are very, very free, and their freedom end up in causing COVID as well. So free radical generation, Chinese are free. So free radical generation, that will be again toxic for the parasites. So in this one, heme polymerase inhibitor and other heme polymerase inhibitor and other anti-malarial ka important mechanism of action has also been discussed. False statement about the side effect profile and drugs used for diabetes mellitus. DPP-4 inhibitor is causing nasopharyngitis, URTI and headache. Yes, that is a correct. This is not false. SGLT2 inhibitor, UTI, vulvovaginitis, weight loss, Fournier gangrene. This is also correct. There were previous report that also supported that it causes fracture risk like canagliflozin, but now that is denied now. Incretins causing acute pancreatitis, PPAR alpha agonist. Incretins can also cause pancreatitis. Any drug that is working at the level of pancreas, they can cause pancreatitis. PPAR gamma agonist. PPAR gamma agonist that we have, sorry, PPAR alpha तो वहाँ पे था ना हमारे फाइब्रेट्स में, गामा यहाँ पे आएगा. PPAR gamma agonist, weight loss. No, they mainly cause sodium and water retention. Because of main sodium and water retention, will there be weight loss or weight gain? Weight gain होता है. तो false is this one, weight gain. बाकी सारे side effect I have explained. Weight gain will be seen with the PPAR gamma agonist. Gamma is glucose. Okay, true statement about the drug of choice and combination are all except. सारे के सारे statement true हैं except. पेन का बैटरी भी बार बार खत्म हो रहा है. आप सब लोग के लिए जल्दी से ख़त्म नहीं हो रहा है सेशन, बट एनीवे वी आर अबाउट टू फिनिश. बीच में थोड़ा सा डिस्टर्बेंस हो गया क्लास. ट्रू स्टेटमेंट अबाउट द ड्रग ऑफ चॉइस एंड कॉम्बिनेशन आर ऑल एक्सेप्ट. हेपेटाइटिस बी एंटिकावीर, CMV, गैनसाइक्लोवीर, एस्परजिलोसिस. ओके, आई थिंक वी गॉट हियर. एस्परजिलोसिस का जो ड्रग ऑफ चॉइस होता है दैट इज गोइंग टू बी वोरिकोनाजोल. Mucormycosis, amphotericin B, all are true except so aspergillosis. ठीक है. Voriconazole, CMV में ganciclovir we can use, or the oral prodrug of the same called valganciclovir that can also be used. Entecavir, lamivudine, tenofovir, these are the other drugs that can be utilized in hepatitis B as well. Correct answer for this one is going to be C. Additional, which of the following fibrate has additional uricosuric property? So phenofibrate is the one, because we already know all the fibrate are PPAR, alpha agonistic property. Pha is phi, fibrate, है ना? The one that can also increase the uric acid का excretion is going to be your phenofibrate. They can promote the uric acid excretion. One more drug, एक एग्जाम में क्वेश्चन आया, which ARB is associated with the यूरिकोसिरिक प्रॉपर्टी. तो कौन सा ARB एंजियोटेंसिन रिसेप्टर ब्लॉकर है? दैट इज लो सार्टान. आई यूज्ड टू टेल यू लो, लोअर डाउन एवरीथिंग, लोअर डाउन द यूरिक एसिड. ठीक है. A patient was started on methisergide for his vascular headache or migraine, maybe we used earlier. After few months, he died due to cardiopulmonary side effect. Upon autopsy, what could be the expected finding? So, see, this methisergide has been associated with pleuropulmonary and pericardial fibrosis. So, pleuropulmonary and pericardial fibrosis has been seen. So, will you see hypertrophy? No, there is going to be pleuropulmonary and pericardial fibrosis. Pleuropulmonary and pericardial fibrosis. What are the drugs that are going to be associated with the pulmonary fibrosis? There are so many drugs actually, but again important ones that you should know that is associated with the pulmonary fibrosis. एंटी कैंसर में बहुत सारे हैं, तो पहले वहीं से स्टार्ट करेंगे. ब्लियोमाइसिन and other one is known as busulfan. Then under cancer itself we have cyclophosphamide. They have also been associated with the pulmonary fibrosis. Methotrexate has also been associated with the pulmonary fibrosis. Drugs in other organ system mein, we can talk about, let's say, amiodarone. They are causing pulmonary fibrosis. Amiodarone causing pulmonary fibrosis. Nitrofurantoin as an antibiotic has been associated with the pulmonary fibrosis. Gold salt, ठीक है. Gold salt that we used earlier for rheumatoid, although we are not using clinically, they have also been associated with your pulmonary fibrosis. So bleomycin, busulfan, cyclophosphamide, methotrexate, they are the anti-cancer drug. Others like amiodarone, nitrofurantoin, gold salt, these are the important drug associated with your pulmonary fibrosis. All of them are causing pulmonary fibrosis. Which of the following drug combination is not contraindicated together? That means which of the following can be used together? एक तो हो गया contraindicated together, but यहाँ पे ये नहीं पूछ रहा है contraindicated together. Examiner here is asking which is not contraindicated. All are contraindicated except, ऐसे हो सकता है all are contraindicated except, है ना. Although इस तरह क्वेश्चन ज़्यादा डबल नेगेटिव वाले is highly discouraged by your board, but since there is only one question, I think we can handle this. So which of the following are contraindicated, or all are contraindicated except? So see, 6-mercaptopurine and allopurinol are contraindicated together. Reason being that 6-mercaptopurine, it is one of the hypoxanthine analog. It is one of the hypoxanthine analog, and they are actually getting metabolized with the help of enzyme xanthine oxidase only. Therefore, if there is a person who is already taking xanthine oxidase inhibitor, or if he has been started on allopurinol, there will be increase in the risk of 6-mercaptopurine toxicity. So they should be contraindicated together. Clopidogrel, omeprazole, they should also be contraindicated together. Reason being that omeprazole is an inhibitor of microsomal enzyme CYP2C19, which is a very potential enzyme for the activation of clopidogrel. Clopidogrel is a P2Y12 inhibitor, that is a pro-drug. It gets activated by CYP2C19. Therefore, they should also be contraindicated together. Stavudine, zerovodine, it inhibits the intracellular phosphorylation of stavudine. So stavudine is one of the NRTI, zerovodine is also one of the NRTI, nucleoside reverse transcriptase inhibitor. One rule for NRTI that you should know, that NRTI always require phosphorylation for their activation. NRTI को हमेशा phosphorylation चाहिए for their activation. So this zerovodine, it is inhibiting the stavudine का phosphorylation. Therefore, zerovodine, stavudine should not be given together. Aspirin and ranitidine, there is no contraindicated, because ranitidine is a S2 blocker. Aspirin is a COX inhibitor that is going to increase the risk of peptic ulcer disease. So for that we can add. So which is not contraindicated. These two are not contraindicated together. The question can be which of the following two combination given together, or which two combination are used safely. So again the answer will be aspirin ranitidine. Next is 29-year-old male started on griseofulvine for dermatophytosis. Which of the following statement is true about this drug? Griseofulvine is a very, very potent enzyme inducer. You already know. They are also associated with a disulfiram-like reaction because of the aldehyde dehydrogenase inhibiting property. Griseofulvine can cause disulfiram-like reaction, enzyme inducer, and they can also cause lupus-like syndrome. Remember, they are a fungistatic drug. They are not fungicidal. कई बार ये question भी आ चुका है. They are fungistatic. They are not fungicidal. Okay, griseofulvine. So they causes disulfiram. All of them will be correct answer for this one. All of the above. Okay. A protein synthase inhibitor showing bactericidal property. See, the protein synthase inhibitor are actually supposed to be static in nature, but there are some protein synthase inhibitor which is going to make your bacteria like a lash. जो bacteria को lash बना दे. So linezolid. Now linezolid is having dual property. That means it has cidal for some, static for some. Aminoglycoside, cidal mainly. Streptogramines also. Streptogramines. That is going to be your quinpristine, dalfopristine. Sorry. Streptogramines that we have, that is going to be your quinpristine and dalfopristine. They are also having cidal property. So जो bacteria को last बना दे, among the given choices we are having gentamicin, which is one of the aminoglycoside. Tetracycline is one of the 30th inhibitor, inhibiting tRNA interaction with the acceptor site. Erythromycin is one of the macrolide, acting at the 50th ribosomal subunit. Cithromycin is like a variant of the macrolide only. So gentamicin is the only one that is cidal. Side effect like central obesity, buffalo hum. Exactly line आपके exam का question होगा. Buffalo hum, they are associated with your protease inhibitor, and all the protease inhibitor they are ending with the navir. Navir. Fusion inhibitor are going to be drugs like your enfuvertide. Who is going to fuse? HIV is going to fuse with the CD4. तो HIV के ऊपर एक receptor होता है GP41. GP41 पे inhibit करके काम करता है enfuvertide. Integrase inhibitor, they are going to be drugs like your raltegravir, dolutegravir, elvitegravir. They are all tigrategravir. This tigrategravir integrase inhibitor as a drug that we have, they are currently among the first line drug for post-exposure prophylaxis and also for the treatment of the HIV. Whenever you are going to use in the treatment of HIV, remember, if you are going to use these integrase inhibitor in the treatment of HIV, so if there is a HIV patient with the tuberculosis and you are going to use, let's say, dolutegravir based therapy like TLD that we very commonly use, you are supposed to double the dose of dolutegravir, double the dose of DTG, that is dolutegravir. इसके डोज को डबल करना होता है बिकॉज दे आर अ सबस्ट्रेट ऑफ CYP3A4 विच इज गोइंग टू गेट मेटाबोलाइज बाई माइक्रोसोमल एंजाइम इंड्यूसर रिफैम्पिसिन, बिकॉज टीबी में HRZD हम देते हैं. ठीक है, तो वी हैव टू डबल द डोज ऑफ डोलुटिग्राविर DTG. ठीक है, अदर ड्रग्स लाइक वी हैव TLD, तो टिनोफोवीर है, TLD हम यूज करते हैं ना, टिनोफोवीर, लेमिवुडीन एंड डोलुटिग्राविर. सो रिमेंबर, ऊपर के दोनों का जो टिनोफोवीर है, लेमिवुडीन है, दे डू नॉट रिक्वायर देयर डोज एडजस्टमेंट बिकॉज दे आर नॉट अ सबस्ट्रेट ऑफ CYP3A4. डोलुटिग्राविर इज द ओनली देयर सबस्ट्रेट, देयरफॉर यू आर गोइंग टू इंक्रीज द डोज ऑफ डोलुटिग्राविर ओनली. प्रोटियाजोम इनहिबिटर, proteasome inhibitor. So drugs that are having proteasome sound like protein, and zombies love to eat protein. Zombie. Have you seen any zombie movies? Zombies always are going to attack people in multiple numbers. है ना? Zombies are always multiple in number. They are the drug of choice in patient with the multiple myeloma. And zombies, they love to eat protein, so proteasome inhibitor, bortezomib. Other drugs are going to be carfilzomib, again zombie word aa raha hai, ixazomib, they are all going to be zomib. Olaparib, rucaparib, niraparib, they are going to be poly-ADP ribose polymerase inhibitor. They are mainly utilized for ब्राका म्यूटेटेड ओवेरियन कैंसर के लिए यूज कर सकते हैं. पैल्बोसाइक्लिब, साइक्लिन डिपेंडेंट काइनेज इनहिबिटर, ठीक है, सीडीके इनहिबिटर और साइक्लिन डिपेंडेंट काइनेज इनहिबिटर, दे कैन बी यूटिलाइज्ड in breast carcinoma. Breast carcinoma, imatinib is one of the tyrosine kinase inhibitor that can be utilized in gastrointestinal stromal tumor and also CML. दोनों में ही ये drug of choice है. Drug of choice for CML and GIST. Imatinib, it's one of the tyrosine kinase inhibitor. All the NIBs are tyrosine kinase inhibitor. So proteasome inhibitor will be bortezomib. Zombies are always coming in multiple numbers, so drug of choice in multiple myeloma. Now, true combination about the agent used for prevention of the following toxicity are all except. So whenever we read our कीमोमैन, जब भी हम कीमोमैन पढ़ते हैं तो कीमोमैन के साथ एक इंपॉर्टेंट चीज़ें हम पढ़ते हैं, व्हाट आर ड्रग्स दैट वी हैव टू प्रिवेंट द टॉक्सिटी. आईफॉसमाइड इंड्यूस हेमोरेजिक सिस्टाइटिस, वी ऑलवेज यूज मेसना. वी ऑलवेज यूज व्हाट? मेसना. Let me see if I can put a chemoman just for your quick revision. No, don't go, this is not the thank you. Let me see if we have a chemoman का pre-made. कई बार मैंने पहले तो बनाया है. I have made lots of chemoman previously. Okay, luckily I got one. Okay, we got here. All right, so I hope this is one simple image that all of you guys can easily see, and chemoman is always going to help all of you guys in solving one definite question in your examination. एक क्वेश्चन आपके एग्जाम में chemoman से जरूर आता है. चाहे वो कोई भी एग्जाम आप दे रहे हो, there is one definite question on chemoman. All right. Okay, so you can easily see that chemoman का starting from, अगर मैं एक एक से start करूँ, that we have chemoman का big smile, better smile. The better smile के साथ साथ आपको ये भी बता दूँ कि the ear of the chemoman and the kidney of the chemoman. So we are talking about cisplatin that is causing nausea, vomiting, autotoxicity, nephrotoxicity, and to prevent this we are having amifostine. Double B that we have here is bleomycin busulfan that is causing pulmonary fibrosis, and to prevent that we are using perfenidone. Then we are having दो lungs के बीच में we have a heart that trusts everyone, so we have doxo and daunorubicin, and we are also having one more drug that is known as trastuzumab. We also have one more drug known as your trastuzumab. They are also producing cardiotoxicity, and to prevent the cardiotoxic event, we can use dexrazoxane. Cyclo and ifosfamide, C and Y, cyclophosphamide, they can cause hemorrhagic cystitis. They can cause hemorrhagic cystitis. Upper limb, lower limb, all the limbs are in favor or in shape of V. So we have vincristine, vinblastine that can cause peripheral neuropathy, and ऊपर का head देखिएगा V, that is also going to be in form of V, that is vincristine. It is going to cause SIADH. 5 finger of the chemoman, it's going to help you in remembering that painful erythematous palm and sole, that will be hand and foot syndrome. So 5 fluorouracil, and the pro drug of 5 fluorouracil is capecitabine, and pemetrexed P से होता है 5. Pemetrexed P से होता है 5. So all these agents that I have explained here are going to be important for you, and to prevent the toxicity of methotrexate mediated bone marrow suppression we use folinic acid and leucovorin. ठीक है, तो कीमोमैन को एक बार जरूर से आप एक बार देख लीजिएगा. देयर विल बी डेफिनेट क्वेश्चन ऑन कीमोमैन इन योर एक्चुअल एग्जामिनेशन, है ना, बार बार इससे क्वेश्चन आते हैं. नो, cisplatin induced renal toxicity we use amifostine, yes, they are nephroprotective in nature. Doxorubicin induced cardiotoxicity causing dexamethasone, yes. Recent previous INI-CET question है. Methotrexate induced bone marrow suppression, we are using pyridoxine, no. ये पूछ रहा है एक्सेप्ट, तो वी आर यूजिंग ल्यूकोवोरिन, और फोलिनिक एसिड उसी का दूसरा नाम होता है. फोलिनिक एसिड इज बीइंग यूटिलाइज्ड. ठीक है, बाकी सब सही है. I believe this is the last one. A monoclonal antibody that is called anti-angiogenesis used in the metastatic colorectal carcinoma. है ना? तो we always talk about a बेवकूफ रानी, that is bevacizumab, ranibizumab, brulocizumab, pegaptanib. What are these? These are all VEGF inhibitor, vascular endothelial growth factor inhibitor. They are going to act as an anti-angiogenesis drug, and they will be utilized for proliferative diabetic retinopathy. And can also be utilized for colorectal carcinoma, metastatic colorectal carcinoma. है ना? आप इसको एज रिलेटेड मैक्युलर डिजेनरेशन, वेट टाइप ऑफ मैक्युलर डिजेनरेशन के लिए भी यूज कर सकते हैं. ARMD, उसके लिए भी यूज कर सकते हैं. तो वी आर हैविंग बेवासीजुमैब. rituximab is not the one. Rituximab is a Ritu. It's a anti-CD20 monoclonal antibody. Ritu is a very young girl. Trastuzumab is used for HER2 positive breast cancer. ब्रेस्ट कैंसर में यूज कर सकते हैं. Cetuximab can be used for head and neck cancer. Cetuximab can be utilized for head and neck cancer. Okay. So these are the important drugs that we are having in this session today that we wanted to discuss for all of you guys. And I hope all of you guys have enjoyed the session and all of you guys have got through this one. And I hope to see all of you guys in my upcoming classes. And एक बार से जरूर से आप रिवाइज करेगा. You will definitely have questions from these topics because these are the high yield topics from past 5 year में multiple topics जो भी डिस्कस किए गए हैं इसमें वहाँ से क्वेश्चन आया हुआ है. I will see you in my upcoming class. Thank you very much.